Okay, so let me just check, am I audible and the screen is clear so that we can start the session. I will just check. So am I audible? Students, those who are live, please let me know, am I audible? So am I audible, dear students? Please let me know. Yeah, so I am audible and everything is fine. Yes. So yes, I am audible and the screen is clear. So we can start the session now. So actually for today's session, okay, Ajay, Pratap, Deepak, Eagle's Eye, Devesh, Shingal. Actually, what I have targeted for you, what I feel that just before the exam, actually the exam is near, and after giving a thought which will be the most important thing for you before the examination, I have collected all the MCQs of the previous year. So starting from 2018, so I am going to discuss the important topics and the MCQs. Exactly what happens when we go through the MCQs, as we know that INICET exam happens twice a year. That means if we are going to solve the MCQs of the last 5 to 6 years, so I want everybody to be live and solve the MCQs along with me, so that it will be very useful for you, and we will solve as many as MCQs we can do, and that will be highly beneficial for you. So all the students, please solve the MCQs along with me. So can we start? Rahul, KK, Deepak, Mohit, Osama, Devesh, Ajay, Eagle's Eye. Okay, let's start with the first MCQ. Okay, so I'm starting with the NEET PG 218 anatomy MCQs. So let's start with this. So identify the type of muscle shown in the image below, and we have got 4 options. As you can see, there is the options given is cruciate, multipinnate, parallel, and the spiral one. So everyone, I'm checking the messages also. So can you tell me which would be the best answer here? Yes, Osama Sheikh, Rahul, can you tell me which is the best answer? So I just want, if you want, I can just highlight the image. So can everybody see the green color highlighted image here? Yeah. So this is the green color highlighted. Can you tell me the name of the muscle? Can everybody tell me the name of the, yes, Sivam, yes, Saurabh Datta. Okay, so I got a B answer and I got a D answer. I want everybody multi-pinnate. Okay, many of the students is telling B and many of the students are telling D. So if I have to go with the right answer, so few students are telling cruciate. No, no dear, the correct answer is, now the correct answer, the identification of this muscle is, which is this muscle? Can anybody tell me the name? This muscle is pectoralis major muscle. So this is pectoralis major muscle. And okay, so yes, Prajwal, congratulations to congratulations to Prajwal. So what you can see, this is the pectoralis major muscle, and you can see pectoralis major muscle is having a vast origin. It is having origin from this clavicle and also originating from the anterolateral aspect of the sternum, and few fibers from the external oblique muscle. And you can see here is the insertion. Yes, you are absolutely right. This is the insertion point. So what you can see, the muscle is having a large origin, and on the insertion point, the fibers are twisted. The fibers are twisted and pectoralis major is inserted into the lateral lip of the bicipital groove. So exactly that means the correct answer will be spiral. So the correct answer here is spiral, and those who have given D will get a thumbs up from me. Now let me tell you why this is the right answer. Cruciate is not the right answer. Can anybody tell me the example of cruciate? When I am using the word cruciate, what does that mean? So exactly, cruciate example will be sternocleidomastoid muscle, masseter muscle. So the fibers are crisscrossing each other. Okay, so this is a question from the general anatomy, and when the muscle fibers are crisscrossing each other, it is called as cruciate. Multipinnate, the right answer is middle fibers, or you can say acromial fibers of which muscle? Can anybody tell me? Multipinnate, which muscle? Deltoid. So exactly, deltoid muscle middle fiber or acromial fibers is an example of multipinnate. And parallel muscle is, yes, Alia, you are absolutely right. And when I am using the word parallel fibers, the parallel fibers are the muscles like sartorius muscle and all that suprahyoid, infrahyoid muscle. Okay, so exactly spiral is the right answer. Yes, spiral is the right answer. And the green color highlighted muscle is pectoralis major, and which muscle are called as the twisted fibers having the twisted or spiral, like latissimus dorsi, like the muscle like pectoralis major, the trapezius muscle, all these becomes an example of spiral. Okay, can we move on to the next? Now moving to the next. Newly erupted teeth is covered by which of the following? Newly erupted tooth is covered by which of the following? Newly erupted tooth is covered by pericremata, nismathmus membrane, fibrous tissue, all of the above. I want everybody to be going along with me, because I want to cover 6 years MCQs today. So I am going to cover 5 to 6 years of MCQ and the topics in quick, because it will be a fast track revision for you. Yes, yes, Sufan. Hello to everyone. Hello to everyone. Can anybody give me the right answer? A newly erupted tooth has got a covering of all of the following or any one of it. It is the pericymata, it is the nasmath's membrane, and it is the fibrous tissue. According to you, which is the right answer? Yes, a right answer is coming from Rahul, Osama, Sheikh, and absolutely correct. Yes, absolutely correct. The right answer is definitely, the right answer is nasmath membrane. Yes. So what you can see, if I have to show you the membrane, which is also attached on the epithelium, actually this is also called as reduce. The other name of nasmath membrane is, it is called as enamel epithelium. What is it called as? It is called as the epithelium enamel. It is covering the newly erupted enamel. So it is covering the newly erupted enamels and the teeth. So it is covered. If I am talking, it is also a question of MDS, but we will it was asked in the NEET PG, it was asked in the INICET exam 2018, and the outer or upper aspect of the newly erupted tooth was having a covering of these epithelium, which called as the reduced enamel epithelium or nasmath membranes. So can the next question, so the next question is coming up, please mark the right answer. So yes, the next question is, hard palate is containing keratinized submucous layer, minor salivary gland, keratinized absent submucous minor salivary gland, non-keratinized, the submucous minor salivary gland, non-keratinized, absent submucous or minor. So there is a combination of, this is a question again of histology, and you have to mark the right answer. Combination options are given and you have to choose the most correct one. So I got an answer from D. Some students are telling D and some students are telling B also. So we have to go with most correct answer. We have to go with most correct answer. Actually, I can understand. Actually, this is slightly confusing because in many of the literature, it is given in the books that it is having multiple epithelium and different location, but most probably non-keratinized. The answer is non-keratinized, but we will go with keratinized one because in the adult hard palate, there is also the deposit of keratin. So we will go with the keratinized one, and absolutely there is the presence of submucosal layer with few of minor salivary gland. So we'll go with keratinized submucosal layer along with the minor salivary gland as the most correct answer. Okay. So you can see this. This is exactly the epithelium which I am showing. The hard palate is actually having epithelium which is keratinized. Okay. In most of the location, it is non-keratinized, but it is also in the adult. If I am talking about the adult hard palate, it is having keratinization also. L for lamina propria and S stands for the submucosal layer, and it will have the part of bone. It is attached to the bone. So if I have to choose the most correct answer, I will go with the keratinized epithelium. And if I talk about the underlying structures, it is also having lamina propria. So it is having lamina propria, and it is also attached to the bone by the fibrous membrane. Actually, you can pay attention to this point. In adult, the epithelium of hard palate can be keratinized. So if I have to choose the most correct answer, this was slightly confusing question, but if I have to choose most correct, I will go with keratinized. Submucosal and few minor salivary glands are also present in the hard palate. So we will go with A as the right answer. Now, tensors. Which of the following is the correct answer? Tensors of the vocal cord. Which is the tensor of the vocal cord? whether it is cricothyroid, whether it is lateral cricoarytenoid, thyroarytenoid, or posterior cricoarytenoid. Actually, if we see the previous year of questions, the action of the intrinsic muscles of larynx is asked so many times. So it is important that you should know this. Okay. So which is the tensor, dear? Which is the tensor of the vocal cord? Which muscle is regarded as the tensor of the vocal cord? So Eagle's Eye, Ali, Ram, Rahul, Ayush Tiwari. I'm also checking the mobile and seeing whether you are participating or not. Yes, so I'm very happy that most of you have given absolutely correct answer. Yes, cricothyroid is the correct answer here. Can anybody tell me the nerve supply of cricothyroid? So yes, yes, Sivam Kumar, I am going to discuss all the 6 year MCQs. So today I want everybody, maybe the session can go half an hour or 1 hour more, but I want to discuss all the MCQs of the 6 years of the INICET exam. So yes, most of the students are telling A and they are absolutely correct, and a thumbs up goes for you all. Absolutely correct. Yes, dear. Yes, yes. Vocalis is also causing, actually vocalis muscle is also causing the tension, but if I have to choose most correct answer, I will go with cricothyroid. Actually, here posterior cricoarytenoid can't be the answer. What is the function of posterior cricoarytenoid? Can I? Yes, yes, external laryngeal nerve is absolutely right. This is a muscle which is the only muscle among all intrinsic muscles of the larynx which is getting innervation from external laryngeal nerve, which is a branch of superior laryngeal nerve. And all these are wrong because lateral cricoarytenoid is adductor of vocal cord. Posterior cricoarytenoid, dear, can anybody tell me posterior cricoarytenoids are the only abductors, the only abductors. So I just want everybody, as we will also discuss briefly about the topic, so I just want everybody to have a note and quick revision of the action of intrinsic muscles of the larynx. So see here. So here we have got 4 muscles, okay, and you have to know the action of each muscle. So basically, yes, you are absolutely right, Eagle's Eye. So I have categorized the muscle. So let's focus on this. So if I am talking about the muscle categorization, so we will categorize the muscle as the in basis of the action. So let's categorize as the first group of the muscle which can open or close the laryngeal inlet. So if I am talking about this group of muscle, they can either open or close the laryngeal inlet. So if I am talking about thyroepiglotticus, this is the one muscle which is opening the laryngeal inlet. Yes, 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 you are absolutely right. Safety muscle of the larynx is the posterior cricoarytenoid, which is only the abductors of the vocal cord. Absolutely right. So this is also important. The one muscle which is opening up the laryngeal inlet is the thyroepiglotticus, and oblique and aryepiglotticus is both closing the laryngeal inlet. Now, talking about the other group of action, that the muscles which are abducting or adducting the vocal cord. Actually, so many times it has been asked, and the correct answer is the posterior cricoarytenoid is the abductor, and lateral and transverse are the adductors of the vocal cord. Now, the question which has been asked was about the cricothyroid, and we can clearly see this is the one muscle, that is the cricothyroid, which is the only muscle which is tensioning the vocal cord. Vocalis muscles anterior part is contracting and tensioning. So if I am talking about vocalis muscle, its anterior part is tensioning. But if I talk about the posterior aspect, it is relaxing the vocal cord. Thyroarytenoid is also relaxing the vocal cord. So absolutely. Yes, dear. If you go through, yes, sleeping curly, yes, if you go through this session, this will be highly beneficial for you. And I can tell that 80% of the questions will be from these topics only. 1 or 2, I have to take more time, but I think 80% questions from this topic. And these questions in INICET, what we have seen in the previous year, the topics are much more repeated. So it's a very good thing that we should revise all the topics and the question before the exam. So everybody, can we move to the next? Can we move to the next MCQ? Ureteric bud. Ureteric bud develops from which of the following? Which is the correct answer? Ureteric bud develops from which of the following? Ureteric bud develops from which of the following? The option given is mesonephric duct, the metanephric mesoderm, the pronephros, and the genital tubercles. Can anybody give me the right answer here? Dear students, which is the right answer? Ali Sufia is telling, okay, A. So I got eagle's eye, I got Subham, Mittal is telling A, we got Sandrayam, Ram, Tushar, Mudra, everyone is telling A. And I feel most of you are absolutely correct. Absolutely correct. The correct answer is mesonephric duct. Absolutely correct, dear. Absolutely correct answer. Let me show you this. So actually, if you talk about ureteric bud, it is actually an outgrowth from the mesonephric duct, which is arising near the cloaca. Okay, and after several generation of this ureteric bud and dividing, what happens? They can give rise to the renal pyramid, major and the minor calyces. Actually, you can see this is the ureteric bud, and you can see it is penetrating through the metanephric mesoderm and it is lying close to that of cloaca. So, mesonephric duct will be the right answer. Mesonephric duct is the right answer. Metanephric blast. So, other option was, so absolutely we have got the right answer, but I want everybody to rule out the other option. So exactly pronephros can't be the right answer because they are not forming the permanent kidney. Let's see the B and D option. So if I am talking about the B, why metanephric? Why metanephric? Why the metanephric blastema is not the right answer? Actually, metanephrogenic blastema is also called as metanephric mesoderm, and actually it is giving rise to two embryological structure which will ultimately form the kidney. So exactly it is basically one of the structure which is giving rise to the kidney, and the other is ureteric bud, which is budding out from the mesonephric duct. Genital tubercles are also not the right answer, because when I am talking about genital tubercles, it develops in the female, it gives rise to the clitoris in the female, and this genital fold is there. If I talk about the genital fold, it will form the labia minora, genital swellings will form the labia majora, and labiosacral fold will form and fuse to form mons pubis. In males, the genital tubercle develops in the primordial phallus. So I just want everybody, you should go through this and you should be knowing the incorrect options also. Let's move on to the next. All of the following structures are involved in Weber syndrome except. So Weber syndrome, it is involving which part of the brain stem, whether the medulla, whether the pons, or whether the midbrain. All of the following structures are involved in Weber syndrome except corticobulbar tract, the oculomotor nerve rootlets, the cerebellar peduncles, or the corticospinal tract. Yes, everyone, eagle's eye, Tushar, Pinky, Anjana, Ali. Please mark the right answer. So, dear students, according to you, which is the structure which is not involved in the condition of Weber syndrome? Yes, you are right that Weber syndrome involves the midbrain. So now in midbrain, if you will see the transverse section of midbrain, which is taken at the level of superior and inferior colliculus, you can see the structures lying inside in the transverse section. So you have to just tell me which of the following is not involved in that transverse section. Yes, Pinky, Tushar, everyone is right. Let me explain it. No worries. If you have forgotten also, I will just give you a quick revision of it. We will have a discussion of the syndromes. So again, but I got many of the students again coming up with the right answer. The Vignesh is coming with the right answer. Bhuana, Ali, yes, cerebellar peduncle is absolutely right answer. Again, a thumbs up goes for everyone. Absolutely correct, dear. So if I talk about this, it is a right answer, and will tell me why. Actually, when I am talking about Weber syndrome, the characteristic feature of the Weber syndrome is it's also called as the midbrain stroke syndrome, which is also termed as superior alternating hemiplegia. Okay, so basically here what happened, the portion of midbrain is involved, and closer to the area we have got exactly, it is middle portion of the midbrain being involved, and it is involving the oculomotor nerves, interpeduncular system, and cerebral peduncle. So which structure, please note down, not the cerebellar but the cerebral peduncles are involved, and there will be lower motor neuron type of oculomotor nerve palsy and contralateral hemiplegia. So whichever condition, if we have got ipsilateral cranial nerve and the contralateral hemiplegia is involved, so this kind of syndromes are called as alternating hemiplegia. This is superior alternating hemiplegia. Okay? Now the structures. Now it is very important to know the structures being involved and what are the characteristic features. So if I am talking about the Weber syndrome, there is involvement of substantia nigra, which is causing contralateral Parkinsonism. There is involvement of corticospinal tract. That is the reason there will be the involvement of lateral corticospinal tract and there will be contralateral hemiplegia. Corticobulbar tract is the region of involving the, if we talk about the other structures being on, lower muscles being involved, okay. And oculomotor nerve is very important, and oculomotor nerve is involved. That is the case of the features which will be seen in this case. There will be, if oculomotor nerve fibers are involved, the features will be seen is the partial ptosis. There will be partial ptosis and all the extraocular muscles will be paralyzed except lateral rectus and superior oblique muscle. So here we can see this is the Weber syndrome, which was other syndrome of midbrain. Actually, paranoid syndrome does not have much of features because it is just having it is mainly seen in the case of pineal gland tumor and there is involvement of just upward gaze. Benedict syndrome is another syndrome. So we will also know the features of Benedict syndrome, because if Weber syndrome was asked, it can happen that they can ask the Benedict syndrome, which is another paramedian syndrome of the midbrain. And here the important structures being involved is oculomotor nerve, causing again the features like loss of oculomotor reflex, yes, and there will be yes, down and out, yes, you are absolutely right, down and outward features of the eyeball will be seen. Why? Because lateral rectus is still functioning and superior oblique is still functioning, and we know that lateral rectus muscle has got an action of abduction of eyeball. It moves the eyeball laterally, and superior oblique will cause intorsion and also will cause the depression. Contralateral loss of proprioceptor vibration center and involuntary movements. Now let's move on to the next question. All of the following statement about Sibson's fascia is correct except. Yes, you are absolutely right. Bhuwana, you are absolutely right. All of the following structures are true about the Sibson's fascia. What is the other name of Sibson's fascia? You can also mention, and you can tell me which is the wrong statement about the Sibson's fascia. So, Sibson's fascia is actually forming a protective covering from the covering for the apical part of the lung, which is covered by the apical or cervical pleura. Now it has got relation. It has got an upper and the lower aspect, and it is lying in relation with some vessels. So that would help you to get the right answer. Its apex is attached to tip of transverse process of T1. So one of the students, Anjana Sarma, has given B answer. What about others, dear? What about others? So Anjana, still I am waiting for others. Ma'am, will you take a separate another session for December FMG exam, Pinky? Yes, why not, dear? We will come to that also. Don't worry. We will have an FMG session also. Don't worry. Sure, Pinky, don't worry. Don't worry. So, I think I have got a right answer from Anjana. I have got a right answer from Bhuvana. I have got a right answer from Alia. Yes. So, its apex is not attached to transverse process. It is attached to the cervical vertebra. It is attached to, no, it's not T2, dear. It's the cervical vertebra. Okay. See here. This, I will show you an image for it. You can see this is the apical. Here lies the apical part of the lung, which is covered by suprapleural membrane. The suprapleural membrane is also called as Sibson's fascia. It is also called as Sibson's fascia. For the last question, dear, last question. This one, dear, the correct answer is cerebral peduncle. Siv Kumar, the correct answer is cerebral peduncle. It is not involved in case of Weber syndrome. Corticospinal tract, corticobulbar tract and oculomotor nerve rootlets are involved. Siv Kumar, is it okay? This was the answer of the previous question. Is it okay? Now coming to this one. So here you can see it is called as Sibson's fascia, which is also called as the diaphragm of superior thoracic aperture. It is also termed as a diaphragm for the superior thoracic aperture. And if you will see the attachment of Sibson's fascia, it is not attached to the thoracic vertebra, but it is attached. The apical part is attached to the transverse process of C7 cervical vertebra. So this was the wrong statement about Sibson's fascia. What is the attachment? It is attached to the transverse process of C7 cervical vertebra, and lower aspect you can see, or basal aspect, it is merging with the inner aspect of the first rib and its adjoining costal cartilage. It is also overlapped by the subclavian vessels. As you can see, it is also overlapped by the subclavian vessels. So is it okay, everyone? The one important aspect is, if we go for the apical aspect, it is attached to the transverse process of C7 cervical vertebra. If I go for the lower aspect, it is merging with the first rib, basal aspect, crossed by the subclavian vessels. So all other options are absolutely correct. Only the wrong option was. So if I talk about the first option, it is absolutely true statement. It is called as the diaphragm. Its base is attached to the inner aspect of first rib. It is true, and it protects the underlying cervical pleura. The wrong option is B. Let's move on to the next one. Yes, Pinky. Let's move on to the next one. Thrombosis of posterior inferior cerebellar artery causes. So see here, what I told you, brainstem syndrome is a very important topic for INICET exam, for the NEET PG exam also, and also for the FMG exam. So many times the question has been asked from this topic. So if I am talking about the thrombosis of posterior inferior cerebral artery, it will lead to which of the following condition? Whether it will lead to medial medullary syndrome, whether it will be leading to the lateral medullary syndrome or the Weber syndrome. So yes, Eagle's Eye, Nitin, Anjana, Bhuvana, Vignesh, Alia, everyone is coming up with the right answer. And my dear students, you are absolutely right. It is called as lateral medullary syndrome. The other name of lateral medullary syndrome is PICA syndrome. It is also called as Wallenberg syndrome. It is also called as Wallenberg syndrome. So actually, this is the right answer and the most common artery to be involved in this case. Yes, a thumbs up goes for you, and it has been asked so many times, and the most common artery involved in this case is the vertebral artery and branch of it, that is posterior inferior cerebral artery. Weber syndrome is not the right answer. It's a syndrome affecting midbrain. Medial medullary syndrome will be involved in the injury of spinal artery, anterior spinal artery. So now I just want you to show this condition so that you can able to understand. Yes. So exactly, if you will see this condition, this is a condition of lateral medullary syndrome, which is also called as Wallenberg syndrome. Now in this syndrome, what happens, my dear students? The dorsolateral part of the medulla is involved. The blood supply, there is a poor blood supply or ischemia of the blood supply for the dorsolateral aspect of the medulla, and the artery which is ischemic, which is affected in this case, will be the vertebral artery or its one branch, that is the PICA artery, posterior inferior cerebral artery. Now the next image which is correlated here is the dorsolateral aspect of the medulla, this one, and exactly here all the structures being involved will be inferior vestibular nucleus, the nucleus and tractus solitarius, ICP, inferior cerebellar peduncles, the spinothalamic tract, nucleus ambiguous. Actually, there is so many signs and symptoms which is associated with this condition. I want everybody to quickly revise all the clinical signs and symptoms which is associated with the lateral medullary syndrome. So we should go with this details. So let's come up with this. When I'm talking about lateral medullary syndrome, it's a neurological disorder which has got a range of symptoms associated with the medulla oblongata. Which part is it? It is the dorsolateral aspect of the medulla, and the artery being affected is the vertebral artery and that of PICA artery. Now, if I am talking about the other name of lateral medullary syndrome, it is called as Wallenberg syndrome, PICA syndrome, or also vertebral artery syndrome. So, one of the students, Nitin Prakash, has given a very important correlation and a very important aspect about this syndrome is that vertebral artery is more commonly affected by PICA artery. So, again a thumbs up goes for Nitin. A thumbs up goes for Nitin. He is absolutely right. So, it's absolutely the right one here. Now, if I talk about the dysfunctions which is associated with it, so if I am talking about the vestibular nuclei, the vestibular nuclei will be affected. Vestibular nuclei is basically the part of cochleovestibular part, and it is having the function of balancing. So the balance will go. Inferior cerebral peduncle, that means cerebellum signs will be associated with it. That means the person will have dysdiadoconiosis. So he or she is not able to perform two movements in succession. Dysdiadoconiosis, he or she is not able to balance. Ataxia will be there, and like for example, if you tell this patient to touch their nose with their closed eye, they will have either they will go up and down. So the features will be of the cerebellum being involved, that is the ataxia, dysmetria, past pointing and dysdiadochoniasis. So other than that, there will be palatal myoclonus, lateral spinothalamic. Now one of an important point which I want everybody to understand, actually whenever there is a case of lateral medullary syndrome, there will be involvement of contralateral side pain and temperature sensation will go, but the same side pain and temperature sensation will go in the face. Actually, this is the reason why I will, there is involvement of lateral spinothalamic tract. So there is involvement of lateral spinothalamic tract, and when the lateral spinothalamic tract is involved, there will be, actually when I am talking about lateral spinothalamic tract being involved, okay, I'm just a minute. I'm so sorry for it. I want to connect my charger. Is it okay? Just 1 second, my dear students. I know your time is very much precious than me. Oh, just 1 second, dear. 1 second. It has. I just want to charge my laptop. Just 1 second, dear. Okay. So yes. Okay, so basically what happens, whenever there is a case of lateral medullary syndrome, if I am talking about lateral medullary syndrome, there will be contralateral pain and temperature gone. Okay, contralateral pain and temperature from the body gone, but same side face pain and temperature will be gone due to involvement of spinal, trigeminal nucleus and tract. Now, if I am talking about nucleus ambiguous, if I am talking about nucleus ambiguous, hypotonia, dear, hypotonia, pinky hypotonia. Okay. Now we will come to nucleus ambiguous. So everybody is knowing nucleus ambiguous is a composite nucleus for 9, 10th and 11th. 9, 10th and 11th. Okay. 9, 10th and 11th. So that means the muscles of pharynx, larynx, soft palate all gone. All the muscles. Is it okay, Pinky? So 9, 10th and 11th and all the muscles will be paralyzed, and sympathetic fibers will be involved. So there will be also the condition of Horner syndrome associated with it. Now, the next question is Broca's area is situated in. Broca's area is situated in. The next question is Broca's area. Okay. Is it okay, Pinky? You got the answer, Pinky? It was decrease muscle tone. Decrease muscle tone. Okay. Decrease muscle. So now I have got many answers coming up from my dear students, and they are telling inferior frontal gyrus, and a thumbs up again goes for you. Yes, dear, inferior frontal gyrus is absolutely right answer. Yes, it's an absolutely right answer. Because Broca's area, can you tell me the numbers of the Broca's motor speech area? The numbers of the Broca's motor speech area. Okay. Everyone, you all are absolutely correct. Now my next question to you is, everyone is absolutely correct. My next question to you is, Broca's area is situated in which of the following area? Okay, so what is the number of that? It is called as area number? No, 41, no Nitin, no Nitin. 41 is auditory, 41 and 42 is auditory cortex for hearing. Yes, Shatish, a thumbs up goes for you. It's 44 and 45. That is pars triangularis and opercularis. Yes, yes, absolutely right. Let's come to that point. Yes, 44 and 45. Absolutely correct. Now, Broca's area is the region in the frontal lobe. When we are talking about the Broca's area, it will be in the dominant hemisphere. Okay, usually the dominant cerebral hemisphere is usually left side, because most of us are right-handed. If we are left-handed, then our dominant brain part will be of the right side. And if there is involvement of Broca's aphasia, we are not able to express ourselves. So there will be expressive aphasia. The person is able to understand, but he or she is not able to fluently speak. Okay. So basically, the area of inferior frontal gyrus which is involved is, you should just note down, it is the pars opercularis and that of pars triangularis. That means area number, broadband area number 44 and 45 of which ear? Of dominant hemisphere. Yes, dear Alia, it was a question asked in the NEET PG, expressive aphasia. Yes, dear, you are absolutely right, Alia. Now, have a look on this. So, when you see the supralateral aspect of the brain, what you can absolutely see, the Broca's area located in the inferior frontal gyrus. It is located in inferior frontal gyrus. Now, my dear students, these are the visual areas in the occipital regions. These are the others, that is the, we know that pre-central gyrus will be the motor area, primary motor area. The post-central gyrus will be the primary sensory areas. Now, I would also like to tell you about Wernicke's area, because if the question has asked from the Broca's speech area, motor area, I just want to correlate with the other one, that is the Wernicke's area. If I am talking about the Wernicke's area or the region of the brain, it is important for the understanding. So, in this case, mainly the area which is involved is of superior temporal gyrus and the area number 22. Also, area 39 and 40 is associated with it, but area number 22 is involved, and the patient is able to express, he or she can fluently speak, but not a single word is understood today. So, they are not understanding what they are speaking. That is the thing. So, Brodmann's area 39 and 40, that is angular and supramarginal gyrus, is also correlated with it. Okay. Yes, Nitin, we will come to one of the question is there with the association fibers also. Yes, Nitin, don't worry, all the topics will be covered up. I think one of the question is there on the fibers. So, there I will explain. Is it okay, Nitin? Yes, absolutely right there. Sensory aphasia. The patient will have sensory aphasia. Now, can you tell me the function of the muscle shown in the diagram? So, I will just enlarge the muscle so that you have an idea of identification of the muscle, and then we will come with the action of that muscle at which joint? Metacarpophalangeal joint. I want everybody to know about the action of this muscle at the metacarpophalangeal joint. Okay, dear? So, see here, I am just enlarging this image. So, when I am enlarging this image, the green color muscle has been shown to you, which is attached to one of the tendon. The hint which is given to you is that it is attached to one of the tendon. So, you can see it is attached to the tendon which is going till the level of distal phalanx. Can you see the tendon is going till the level of distal phalanx? So, the tendon, I am just rubbing this, that was just for a hint. So, now tell me what will be the action of the muscle at metacarpophalangeal joint? Function of the muscle at the metacarpophalangeal joint. Which muscle is this? Now, please tell me which muscle is this. No, I think everyone is confused about this. I think I should revise you about this topic. My dear students, you are confused. Now, can everybody identify the muscle? Let me again enlarge this. Now, the other hint which I will give it to you, see here, these are unipinnate. These muscles are unipinnate, and this is the muscle which is bipinnate. Now, my dear students, you can, I got a right answer from Alia. Alia is absolutely correct. Yes, dear Alia, you are absolutely correct. She has given a right answer. This is third and fourth lumbrical muscle. Yes, dear, which is arising from the tendons of FDP, flexor digitorum profundus, and this is first and second unipinnate muscle. Don't worry, Vishal. I will also have a question where I will describe you about the introsia, dorsal introsia and palmar introsia. Everybody be connected for this live session. All type of questions are coming up. Okay, don't worry. The ultimate goal of the session is to revise entire anatomy, most important topic. Okay, I will try to cover up 90% questions of the 90 or more than 90% questions most important from the last 6 years. Okay, so yes. So, this is the clue. Yes. No, Vishal, why not dorsal introsia is the right answer? Because all dorsal introsia are bipinnate. All palmar introci are unipinnate. This is lumbrical muscle. Now, for understanding the action of lumbrical muscle, which is a small earthworm-like muscle which is attached to the tendon of FDP. Now, how we are knowing that this is the tendon of FDP? Now, see here, if this, see here, I am just marking this muscle tendon. This is, so this is actually, this is the muscle tendon which has been shown. And if you will see this diagram, what you can appreciate that this muscle tendons are going till the level of distal phalanx. So this are going till the level of distal phalanx. So this muscle is which muscle? This is FDP, flexor digitorum profundus. This is flexor digitorum profundus. And the muscles, small earthworm-like muscle which is attached to it is the lumbrical muscle. Now, if you want to know the action of lumbrical muscle, you have to just make your hand like this. See here. Got it, dear? What is this action? This is the action. That means the muscle, the lumbrical muscle is causing flexion at the metacarpophalangeal joint and extension at interphalangeal joint. So what will be the right answer? Yes, Navdeep has given a right answer. Alia has given a right answer. Anjana has given a right answer. Okay, the right answer is flexion at metacarpophalangeal joint. Absolutely right. Flexion at metacarpophalangeal joint. Okay. Now, I want everybody to see this diagram. The action of these are the lumbrical muscle which is already known. Yes. So, Alia, you can see here, if you will make your hand like this, like you can say like a cobra, and you can see it is causing flexion at metacarpophalangeal joint and it is causing extension at interphalangeal joint. Extension at interphalangeal joint. Is it okay? Now, acute tonsillitis is involving which nerve? Acute tonsillitis is involving which nerve? The next question is acute tonsillitis is involving which nerve? Whether it involves the glossopharyngeal nerve, whether it involves the facial nerve, the trigeminal nerve or the vagus nerve. Acute tonsillitis is involving which nerve? Okay, dear. Okay, Navdeep has given his answer. Nitin has given his answer. The Reddy has come up his answer. Alia, Pinky, everyone. Oh, no need of explanation. Is the glossopharyngeal nerve. Now, my dear students, absolutely right. Yes, glossopharyngeal nerve is called as the nerve of tonsil. You must have studied this in the ENT also. Now, my next question is only the glossopharyngeal nerve which is giving innervation to tonsil, or we have got another nerve which is also giving innervation to tonsil? What will be the right answer? Can anybody tell me? Is the only glossopharyngeal nerve which is innervating tonsil, or we have got another nerve innervating tonsil? Can anybody give me the name of that nerve? Yes, Piyush, Tushar, Dhanus, Amit, Kumar, Alia, Pinky, Satish, Nitin, Shravan, Reddy, everyone. So, the other one is the lesser palatine nerve. So, actually, if I have to tell you about the entire innervation of the tonsil, two nerves are there. The one is the one nerve is the glossopharyngeal nerve and the other is lesser palatine nerve. Tonsil receives supply not only from the glossopharyngeal nerve but also from trigeminal nerve. Glossopharyngeal nerve is important. It is giving general sensory and also the taste sensation to the posterior 1/3 part of the tongue and also circumvallate papilla. Lesser palatine nerve, which is a nerve branch from maxillary division of the trigeminal nerve, is also innervating the tonsil. So, tonsil receives afferent supply from the tonsillar plexus and the tonsillar plexus is getting innervation. It is getting its fibers or contribution from the branch of trigeminal maxillary division, that is the lesser palatine nerve along with glossopharyngeal. Is it okay? So, you have to know about the complete innervation of the tonsil. Now, structure not passing through the aortic opening of the diaphragm. Easy one. Easy question there. Easy one. The easy one. Structure not passing through the aortic opening of the diaphragm. Thoracic aorta, azygous vein. Vagus nerve, which is the right answer, which is not passing through the aortic opening of the diaphragm. So here Anjana has given a right answer. Yes, it's a vagus one. It's an easy one. So I'm just going quickly. Is it okay? Ready? Is it okay, Alia? Yeah. So right answer. So can you see we have got following? We have got the following openings in the diaphragm. So we have got an opening which is called as the caval hiatus opening, which is at the level of T8. So this is at the level of T8. We have got esophageal hiatus, which is at the level of T10. We have got the aortic hiatus at the level of T12. Okay, we have got aortic opening at the level of T12. We have got esophageal hiatus at the level of T10, and we have got T8, the caval hiatus. Is it okay? So basically, we can see these three openings which are shown in the diaphragm, and we have to know the structures traversing through this opening. Now here we can see anteriorly we have got anteriorly, if you will see, we have got foramen of Morgagni, and here if we talk about foramen of Morgagni, it's a space which is lying between the sternal and the costal slip of, it is a space which is lying between the sternal and the costal slip of origin of diaphragm, through which the superior epigastric vessels traverses. If I am talking about the esophageal hiatus, we have got the anterior posterior vagal trunks, and along with the esophageal branch of left gastric artery traversing. If I talk about the aortic hiatus, we have got three important structures passing. We have got the aorta, we have got the azygous vein, and we have got the thoracic duct. We have got right phrenic nerve and inferior vena cava which is passing through the vena cava opening, and minor apertures are there for the passage of greater, lesser, and the least splanchnic nerves. So let's come to the NEET PG 2019 anatomy MCQ discussion. Is it okay? Let's come to 2019 MCQ discussion. Okay. So joint involved in the movement of head from left to right. This joint. Can anybody tell me what is the name of the joint? Left and right. Joint involved in the movement of head from left to right. Whether it is atlantoaxial joint, whether it is atlanto-occipital, C2, C3 joint, C3, C4 joint. Much of the answers are coming A, and absolutely correct. Yes, this is the no joint. So exactly we moved it right and the left. That is called as sign of no, which is taking place at atlantoaxial joint. Absolutely a thumbs up goes for you all. Absolutely correct, dear. Yes, that is the no joint. Now exactly atlantoaxial, if we will see here, so this is an articulation which is taking place with the articular facet of the dens part of the axis and that of the atlas, anterior arch of the atlas. And actually a rotational movement from right to left happens along the vertical axis. And this is, if we talk about the median atlantoaxial joint, which type of joint is this? Median atlantoaxial joint. Can anybody tell me median atlantoaxial joint is which type of joint? It is pivot type of synovial joint, and it is a joint of no movement. Okay. Now, other than that, the atlantoaxial joint, the head rotation takes place, and so only it is a connection between first and second cervical vertebra, and it is a rotational movement. It's a no sign. And if I talk about the atlanto-occipital joint, yes, you are absolutely right, Tushar. Atlanto-occipital joint, which is which type of joint is atlanto-occipital? Atlanto-occipital. Can anybody tell me atlanto-occipital? Which type of joint is atlanto-occipital? Yes, atlantoaxial is correct. My next question is atlanto-occipital joint, not the A joint. I am talking about atlanto-occipital. Which type of joint is atlanto-occipital? Yes, absolutely right. It's an ellipsoid type of synovial joint. It's an ellipsoid type of synovial joint. So the principal movement which is taking place at the atlanto-occipital joint is flexion and extension and yes movement. So it's called an yes movement. Nerve supply of submandibular gland. What is the nerve supply of submandibular gland? My next question to you, what is the nerve supply of submandibular gland, whether it is via auriculotemporal nerve, the lingual nerve, the glossopharyngeal or the inferior alveolar nerve? We have got 4 options and you have to go with the most correct answer. Nerve supply of submandibular gland. Auriculotemporal, the lingual, the glossopharyngeal, the inferior alveolar nerve. Submandibular. Okay, A answer is coming up. The correct answer is lingual nerve. Yes, the correct answer will be lingual nerve for submandibular gland and sublingual gland. Auriculotemporal nerve is associated with parotid gland. Glossopharyngeal nerve is associated with the posterior part of posterior 1/3 of the tongue. Inferior alveolar is also not, it will give another nerve to mylohyoid and mental branch. It will give nerve to mylohyoid and mental nerves, and this is also the correct answer will be the lingual nerve here. So what is the right answer? Lingual nerve. Now see here. Actually, when I am talking about the lingual nerve, what you can see, lingual nerve is a branch of, can anybody tell me lingual nerve is a branch of which nerve? So we have got lingual nerve as a branch of mandibular division of trigeminal nerve. Lingual nerve is a branch of mandibular division of trigeminal nerve. So here what happens, the facial nerve is involved and this will be associated with the coda-tympanic nerve traverse along lingual nerve, which will be relaying in the submandibular ganglion. Yes, you are right, Nitin and Anjana, and it will give innervation to both submandibular and that of sublingual gland. So it carries it carries actually parasympathetic innervation, and this is responsible for the secretion of SMG and SL, that is submandibular and sublingual gland. So we will have lingual nerve as the right answer. Right coronary artery arises from, what is the origin of right coronary artery? It arises from right anterior aortic sinus, left posterior aortic sinus, posterior coronary sinus, anterior coronary sinus. So easy one, I will tell you the hint also. It arises from the part of aortic sinuses. Okay, my dear students, please mark the right answer. Right coronary artery arises from which of the following sinus? So exactly these anterior and posterior coronary sinus can't be the right answer. Coronary sinus is draining in the right atrium and all the veins are draining into it. The right answer should be either A and B. So I got an answer from KP. I got an answer from Alia. Yes, right anterior aortic sinus is absolutely correct. If we talk about left posterior aortic sinus, it will give origin to left coronary artery. Left coronary artery. And anterior aortic sinus give rise to right coronary artery. So if I am talking about the origin of the coronary artery is an example of functional end arteries. They are an example of functional end arteries and they are giving arterial supply to the heart. Why they are called as functional end arteries? The reason is that anatomical end artery which is not anastomosing with the neighboring artery. One of the best example of anatomical end artery is the retinal artery, the central retinal artery. If it is injured, total blindness happens. If I am talking about coronary arteries, they are called as functional end arteries. The reason is that right and the left coronary artery anastomose with each other, but their anastomosis is not enough to meet the nutritional or serve the vascular demand of the myocardium, and heart attack will still happen, myocardial infarction will still happen. So anterior aortic sinus is giving rise to right coronary artery, left posterior aortic sinus is giving rise to the left coronary arteries. Now see here, the right coronary artery arises from anterior aortic sinus of ascending aorta, which lies immediately above the aortic valve. So here we have two coronary arteries, right and the left coronary artery, and we have talked about its important origin. The important branch of right coronary artery is posterior descending artery, which is also called as posterior interventricular artery. Anterior interventricular artery or the left anterior descending artery is a branch from left coronary artery. Circumflex artery is also a branch from left coronary artery. So LAD artery is the most important artery to be involved in case of myocardial infarction. Okay. Then the other artery being involved is, we have got three important arteries which are commonly involved in case of myocardial infarction. The one is the LAD artery, the other one will be the circumflex artery, and then we will have also the right coronary arteries being involved. Posterior interventricular artery is most commonly in 90% of the individuals in the population. It is a branch from right coronary artery. So we have got right dominant heart. Now, which nerve passes through the marked foramen in this image? Which nerve passes through marked foramen in the given image? So can you see the black color arrow? And whether it is inferior alveolar, mandibular, coda tympanic nerve or lingual nerve. So first thing is that you have to know four options which I have given. The next thing which you have to know is to see this image and identify the foramen and tell me which nerve will pass through this foramen. Which nerve pass through the marked foramen in the given image? Alia, Tushar, Nikitan, Nitin Prakash, Vishal, everyone has given absolutely right answer. Inferior alveolar is absolutely right answer. See here. So I just want you to show this is the inferior alveolar nerve which is traversing through the mandibular foramen. The mandibular foramen was the image which has been shown, and as you can see, it is traversing through the mandibular foramen and then goes to the mandibular canal, and the nerve which will emerge out through the foramen which is lying below here in the midline. This is the mental foramen, and the structure will come out is the incisive and the mental nerve traversing outside. Now, this is again an image based question. Identify the muscle which is shown in this image. So, actually this is an image where the green color muscle has been shown to you, and you can appreciate the origin is from the humerus and insertion. As you can see, it is shown here where it is going. That is the hint which will give you the right answer. Whether the right answer is brachioradialis, extensor carpi radialis longus, flexor carpi radialis longus, extensor carpi ulnaris. INICT, Siv Kumar, these are all INICTs. INICTs. Okay, so many of you are telling B. Okay. So I just want everybody, I will show you an image where you will know the insertion of most of, so here you can see absolutely. Okay, now KK, no, I think INICT questions are being discussed. Okay, few overlap can be there, few MCQs can overlap, don't worry, but most of the questions are from INICT exam. Okay, KK, most of the questions are from INICT exam. Okay, it's important that we should also go with the high yield topics, no? So it's a mixed bundle of the questions can be there. So actually most of you have given the right answer. So exactly I would like to show why brachioradialis is not the right answer, because brachioradialis is inserting on which structure? It is inserting on the radial styloid process. It is going to the radial styloid process here, and extensor carpi radialis longus is going to the base of second. So it is going to the base of the second metacarpal. So here also it is on the second metacarpal. So yes, ECRL is the right. Extensor carpi ulnaris is also, as you can see, it is going towards the fifth metacarpal and also the pisiform bone. So yes, it is going towards the fifth metacarpal. And if I am talking about flexor carpi radialis, it is going towards the base. As you can see, it is going towards the base of both second and third metacarpal. second and third metacarpal. So if I have to choose with most correct answer, I will definitely go with ECRL. I will definitely go with ECRL, extensor carpi radialis longus. Okay, duct of Bellini is present in duct of Bellini is present in so this is a easy one. Duct of Bellini is present. I think very easy. Yes, kidney, absolutely right. So we can see duct of Bellini, which is collecting duct of Bellini. It is traversing to the medulla part of the kidney. Absolutely, it's a very easy one. I'm not going into much of the explanation. Now, nerve supply of arrow marked area. Question number 7. These are all from INICET. This is a question from INICET. KK, this is a question from INICET. Nerve supply of the arrow marked area shown in the diagram. So please have a look on this. This is the dorsum. So please note down this aspect is the dorsum of the hand. This is dorsum of the hand. And you have to tell me the nerve supply of arrow marked area shown in this diagram. Yes, definitely median nerve is the right answer. Actually, yes, absolutely a thumbs up goes for everyone. Yes, what a good, everybody is having the right answer. So here I just want to show this is the palmar aspect and here this is the dorsal aspect of the hand. So we can see the palmar aspect and we can see the dorsal aspect. So when you see the dorsal aspect of the hand, you can see dorsum 3.5, lateral 3.5 dorsum is by radial nerve and on the medial 1.5 is by the ulnar nerve. And if you see the palmar aspect, you can see most of the part is by medial nerve and the medial aspect is the ulnar. Only you can see on the nail buds. If you see the nail buds on the dorsal aspect, it is also by the medial nerve. So we have got medial nerve as the right answer. Here also another image I have shown you where you can see the innervation both on the dorsal aspect and the palmar aspect. I want everybody to go through this image because image based question can come from this. Now, which of the following is not the boundary of yellow color highlighted triangular area? So, can everybody see this yellow color highlighted triangular area? Now, please tell me which of the following is not the boundary of yellow color highlighted area. Gallbladder, cystic duct, common hepatic duct or cystic artery? So, Tushar, Kona, Alia and Anjana, everyone has given a right answer. Gallbladder is absolutely right answer. Yes, definitely gallbladder is right. Actually, this yellow color triangular area is, can you tell me the name of the triangular area? Can you tell me the name of the triangular area? Everyone, name of this triangular area. This is called as, this triangular area is Calot's triangle. This triangular area is Calot's triangle. Yes. So exactly this is a Calot's triangle. And if we talk about this triangular area, so here the boundaries is defined by 3C. Yes, you are absolutely right. The boundary is defined by 3C. We have got this is cystic artery. This is the cystic artery. It is bounded superiorly by cystic artery. Yes, it is bounded on left hand side by cystic duct, on right hand side by cystic duct and on left hand side by common hepatic duct. So that means common hepatic duct, cystic artery and cystic duct all are forming the boundaries and the content is cystic lymph node. What is the content? Cystic lymph node. So actually I would like to show you this diagram where you can see the small triangular yellow area is Calot's triangle having the boundary with 3C. The common hepatic duct, the common hepatic duct, the cystic duct and the cystic artery. The cystohepatic triangle will have the boundary along with this, it will have the boundary So if I am talking about cystohepatic triangular area, will have the boundary also, it will take consideration of inferior border of the liver. So here we will have inferior border of liver, which will be also taken as a consideration, and we will have on one side the cystic duct and the other side we will have the common hepatic duct. Here the cystic artery is the content. If I am talking about the hepatocystic triangle, we will have the cystic artery as the content, but in Calot's triangle, cystic artery is forming the superior boundary. Okay. Now, arrow marked area in the given image is supplied by. Actually, I will share an image where you have to know about the dermatomal distribution also. So, arrow marked area in the given image is supplied by which dermatome? Whether it is T9, whether it is T10, whether it is T11 and T12. Yes, it's an easy one. It's the T10. Umbilical area is by T10. Yes, so you can see here, basically area around the umbilicus is supplied by T10. I also want everyone to go through the ventral aspect, the dorsal aspect, and see the dermatomal distribution by this image. Have a quick revision of it, and you can see the dermatomal distribution over the whole area of the body, because dermatomal distribution question has been asked in the previous year. Identify the fiber marked in the image. Which type of fiber is this? So, which type of fiber is this? So, you have to identify this structure. What is that structure you have to identify, and which type of fibers are it? Association, long association, commensural or projection fibers? So, many answers are coming up. Yes, projection fiber is absolutely right, right answer. It is internal capsule. This is internal capsule, and the fibers which I am talking is the projection fibers. Yes, absolutely right. It's a projection fiber. Actually, the same diagram I want you to show, where you can see the internal capsule is here, which is having anterior limb, genu and posterior limb, and it is exactly sandwiched between the caudate nucleus and the lentiform nucleus, which is lying laterally. So here we have got caudate nucleus and thalamus forming the medial boundary in the horizontal section. So what is this? This is the horizontal section of the cerebral hemisphere, which is showing the caudate nucleus and the thalamus on the medial side. We have got the lentiform nucleus on the lateral side, and in between we have got the projection fiber. Actually, when I am using the word projection fibers, it is connecting the cortex with the subcortical area. When I am using the term association fibers, it is connecting the part of one hemisphere. So actually it is connecting the adjacent gyri of the same cerebral hemisphere, or it will connect the different gyri of the same cerebral hemisphere. That means association fibers are lying inside one hemisphere only. It is not crossing. So they are intrahemispheric fibers. If I am talking about commensural fibers, it is crossing. It is connecting one cerebral hemisphere with that of the other. So it is called as the interhemispheric fibers. They are called as interhemispheric fibers. Yes, so that is the difference between the three types of fibers, and definitely internal capsule is a long association fibers. Okay, so here also we can see this is the internal capsule, which is regarded as the long association fibers. We can see the parts of the lentiform nucleus. So here we have got the putamen, we have got the globus pallidus, and medially we have got the caudate nucleus and also the thalamus. Now, these are the three fibers which has been shown here. Actually, you can see in this diagram that this pink color fibers are actually projection fibers, which is connecting the cortex to subcortical areas. Here we have got small fibers, as you can see here, that is called as the association fibers. Here corpus callosum is the largest commensural fibers. It is connecting one hemisphere with the other hemisphere. Corpus callosum is the largest commensural fibers. It is connecting one cerebral hemisphere structures with the other one, and we will have adjacent gyri being connected by the fibers, that is called as association fibers. So I just want you to show the association fibers also. So in this diagram you can see different types of association fibers. So exactly these are short association fibers which is connecting the adjacent gyri of same hemisphere. So they are intrahemispheric. other than long association fibers, as you can see in this diagram, the long association. So this diagram is showing you the types of association fibers. So we have got the long one, superior longitudinal fasciculus, uncinate fasciculus. We have got inferior longitudinal fasciculus, and this is the inferior aspect. So here we are seeing the fibers of corpus callosum. So when you see the corpus callosum from the inferior aspect, you can see it is connecting most of the part of right and the left cerebral hemisphere. So they are interhemispheric. Now the next question is, identify the arrow mark structure. Identify the arrow mark structure in the sagittal brain section. Identify the arrow mark structure in the sagittal brain section. Identify the arrow mark structure in the sagittal brain section. So I got an answer here. Okay, absolutely right. Yes, this is fornix, dear. Yes, this is fornix, dear. Yes, this is fornix. This part is the corpus callosum. So this will be the septum pellucidum. This will be septum pellucidum, and flux cerebri can't be this, and pineal gland is also not here. We will have the pineal gland posteriorly. Actually, pineal gland is forming the posterior relation for the third ventricle. Flux cerebri is the part of cerebral meninges, which is sickle shaped, and it is actually lying in the longitudinal fissure. So basically you can see this diagram and you can clearly see that this is the fornix, which is exactly shown here, which is lying below the septum pellucidum. Septum pellucidum is separating the lateral ventricle of both the sides. So this is the will be the location of lateral ventricle, which is overlapped by septum pellucidum, which is lying below the corpus callosum. Corpus callosum is the largest commissural fibers. Okay. Also posteriorly we will have the pineal gland. Posteriorly this will be the pineal gland. So the most correct answer here will be the fornix. This is the fornix. Is it okay? Now dear students, what is the nerve supply of the mark structure given in the image? So please identify firstly the muscle. So exactly you can identify now, because similar kind of image I have explained. So you have to identify this muscle. Which muscle is this? Then you have to tell me what is the nerve supply of this muscle. So firstly you have to tell me what is which muscle is this. Then you have to tell me what is the nerve supply of this muscle. So the option given is medial nerve, ulnar nerve, radial nerve, anterior interosseous nerve. Okay, so yes. So basically which muscle is this? Which muscle is this? This arrow mark. So exactly you can identify it, my dear students. Why not? Because you can see this is unipinnate. These two muscles are unipinnate and this is the bipinnate. Just now I told you this small earthworm like muscle which is attached to the tendon. So here also you can appreciate the tendons of the FDP has been shown. So this is the tendons. So this is the tendon of FDP. This will be the tendon of FDP, which is giving rise to lumbrical muscle. So this is the lateral lumbricals, and we know the lateral lumbricals are supplied by median nerve. Yes, L1. Yes, absolutely right. So lateral lumbrical, the marked muscle is lateral lumbrical, that is the first lumbrical muscle, and the nerve supply of lateral lumbricals, first and that of second lumbricals, are supplied by median nerve. And if I talk about third and fourth lumbrical muscles, the third and fourth lumbrical muscle is supplied by ulnar nerve. The third and fourth lumbrical is supplied by ulnar nerve. Is it okay, everyone? The medial lumbricals are supplied by ulnar nerve, but the lateral lumbricals are supplied by median nerve. So we'll go with median nerve as the right answer. Ulnar nerve is not the right answer because it will give innervation to third and fourth or the medial lumbrical. Radial nerve is not answer because it gives innervation to extensors of forearm. Anterior interosseous nerve is not the right answer because it gives innervation to deep flexor forearm muscle. It is giving innervation to pronator quadratus flexor pollicis longus, and lateral part of FDP, lateral part of FDP, anterior introosseous nerve. Okay, dear, just a minute. Okay, so if I am talking about anterior introosseous nerve, just a minute, let me just connect. Okay. What happened to the lonely screen? Okay, dear students, so is it, so yes, is it okay? Can you see the screen? Please let me know. Can you see the screen, dear? Okay. Ma'am, internal capsule is a long association of projection fibers. Siv Kumar, it is projection fibers. Internal capsule is connecting the cortex area with the subcortical structures. It is connecting, so it is a projection fiber, Siv Kumar, which is the medial side. Okay, how you can understand the medial side? So, my dear students, can you see here? This is little finger, no, dear. This is the first finger, this is second, this is third, this is fourth and fifth. So, little finger will be medially and the first thumb will be laterally. So, we will have this as the lateral. Got it, Alia? Medial side is that which is lying close to the little, means fourth and fifth finger is medial, and these are the lateral fingers. So, that will be the lateral side. Now, identify the marked structure in the given image. Most easy question. Very easy, no explanation needed, I think. Yes, cerebellum. Very easy. It's a cerebellum. Now, nerve injury in Frey syndrome. Yes, it was very easy one. I think everyone must be knowing that. Now, nerve injured in the Frey syndrome. In the case of Frey syndrome, can you tell me which nerve is injured? Whether auriculotemporal, great auricular, lingual or inferior alveolar nerve? So, please don't get confused. Yes, I can understand you can get confused from auriculotemporal and great auricular, but if we have to choose one, we will go with auriculotemporal nerve. We'll go with auriculotemporal nerve as the most correct answer here. Auriculotemporal nerve is the most correct. Yes. I will tell you why. I will tell you because just see here. If I am talking about Frey syndrome, what happens, the injury happens to auriculotemporal nerve, and also we know that great auricular nerve gives innervation to the area. If I talk about entire face sensory innervation, it is via trigeminal nerve. Which nerve is giving innervation to entire face sensory innervation? Is the trigeminal nerve, except that the area around this anterior to the ear, this is angle of mandible, this area is by great auricular nerve. Now what happens? We can see the auriculotemporal nerve is carrying sensory, carrying parasympathetic, sympathetic innervation to parotid gland. So, when the regeneration of the nerve occurs, it joins with the sensory innervation also. So, the cause is damage of parotid gland and that of damage of auriculotemporal nerve. Other name is auriculotemporal nerve syndrome, Ballerger syndrome, Dupy syndrome, gustatory sweating syndrome, gustatory hyperhidrosis. The clinical symptoms when the person is saving or doing anything, there is sweating and redness on this area. Treatment is the injections will be given, botulinum injections and agents. So basically sweating and flushing happens around the cheek, temple and behind the ear. So this is the case of Frey syndrome, and if I have to choose one answer among the both, I will definitely go with the auriculotemporal nerve. Now, which of the following structure are not derived from external oblique muscle? Which of the following structure is not derived from external oblique muscle? Which of the following structure is not derived from external oblique muscle? Inguinal ligament, lacunar, Cooper's ligament, or linea semilunaris? So the most correct answer, yes, linea semilunaris is the right answer, because inguinal ligament. Can anybody tell me what is the other name of inguinal ligament? What is the other name of inguinal ligament? It is also called as inguinal ligament. The other name of inguinal ligament is, it is also called as Poppart's ligament or groin ligament. And if I talk about 4 extensions are there from the inguinal ligament. The 4 extensions of inguinal ligament is called as lacunar ligament. The other name of lacunar ligament is Gimbernet ligament. The other extension is Cooper's ligament, which is also called as pectineal ligament. We will also have the reflected fibers of inguinal ligament, which is extension from the superficial aspect going in upward direction towards the umbilicus. And we have got one extension which is a downward extension from inguinal ligament, which is called as the ilioinguinal ligament. So this is a schematic diagram just to make you understand the extensions. This is an inguinal ligament just to make you understand the extensions from the inguinal ligament. So we can see this inguinal ligament, which is formed from external oblique muscle aponeurosis, which is extending from ASIS, which is extending from ASIS to the pubic tubercle, as you can see here, pubic tubercle. So this is extending from ASIS to pubic tubercle. Okay, and there are 4 extensions. There are 4 extensions from the inguinal ligament. The one name is the lacunar ligament, which is an extension as shown in the medial side. You can see this is a deeper medial aspect, the triangular extension to the pecten pubis. The other name of lacunar ligament is, it is also called as Gimbernet ligament. Gimbernat's ligament. The other extension is pectineal ligament, which is also called as Cooper's ligament. Now, if you will see from the extension, so I just want to use another color, an extension from the deeper aspect of the Gimbernet ligament, which is going till the level of iliopectineal eminences, is called as pectineal or Cooper ligament. There is also a downward extension from the inguinal ligament, and this downward extension, so this downward extension from inguinal ligament is called ilioinguinal ligament, and this is also occurring at the level of iliopectineal eminences. And there is one superficial extension which is called as reflected part of inguinal ligament. Now, if I talk about linea alba or linea semilunaris, it is the lateral edge of the rectus abdominis muscle. So the correct answer is linea semilunaris, which is the lateral boundary of rectus abdominis muscle. It is not an extension from inguinal ligament or Poppart's ligament. Now, can anybody tell me contralateral loss of pain and temperature sensation is due to which of the following structure? Whether the injured structure is anterior spinothalamic tract, lateral spinothalamic tract, fasciculus gracilis, or fasciculus cuneatus. Contralateral loss of temperature and sensation. Loss of temperature and sensation contralateral is due to injury. It's a very easy one. It's the involvement of lateral spinothalamic tract. Lateral spinothalamic tract is actually carrying the information about pain, temperature, sensation, and anterior spinothalamic tract is for crude touch. The gracile and cuneate tubercle was also given as an option, and they are not the right answer. The reason is that they are carrying the information of proprioceptive and light touch. So these are primary tracts and their function has been written. So gracile and the cuneate tubercle is for proprioceptive light touch, Lateral spinothalamic, contralateral pain and temperature, anterior spinothalamic for crude touch. AIMS 2019 MCQs. Can we discuss AIMS 2019 MCQs more? We have discussed the one, we know that AIMS happens in 2 sessions, so this is the next session. This is the MCQ of the next sessions. So this is the image based MCQ. So please mark the right answer. Lesion. So let's come to the next series of AIMS 2019 MCQ. So we have to discuss till 2024. Okay, till 2024. So my dear students, my pace is okay. Is my pace okay? If anyone is finding it difficult in understanding, pace is okay, dear? Please mention in the message so that I can understand whether I should go slow or the pace is okay for you. So Tushar is telling it's a pyramid and the answer will be contralateral hemiplegia. So basically what happens, if we are talking about this, actually this is the image of ventral aspect. So yes, my dear, you can see this arrow is marked on the pyramid and they are absolutely right. This is P for pyramid. Yes, this is P for pyramid. This is P for pyramid and this is showing the, okay, yes, okay. So this is P for pyramid. This is a part of the medulla. So actually the same kind of image I will take, and here you can see this part is the pons. This part is the pons and this is the basilar groove. What is this? This is the basilar groove. This is the basilar groove. Okay, and this part is the medulla. So when we are talking about the medulla, we can see here this part will be the pyramid olive and this is the olive. So we will have pyramid and olive. So we will have medially P for pyramid and then we will have olive lateral. Okay. So exactly if the pyramid, that is the upper part of the medulla, is involved, that means after that in the lower part we have got decussation of the fibers of the pyramid. So that means crossing over of corticospinal tract happen in the lower part of the pyramid. That means corticospinal tract will be injured and in the upper part. So the presentation which will be seen in the patient will be contralateral hemiplegia. Ipsilateral paralysis of palate and pharynx is not the right answer, because in this case the injury should be at the level of nucleus ambiguous, that is a composite nucleus of 9th, 10th and 11th cranial nerve. Atrophy and paralysis of the tongue will not happen because this will involve hypoglossal nerve. Ipsilateral facial palsy, ipsilateral is in the lower motor neuron palsy of facial nerve, and facial nerve is also not involved in this case. So the pyramid is involved and that contains corticospinal tracts. Corticospinal tract lower part, and there is pyramidal decussation where crossing over of the fibers takes place, pyramidal decussation, and above pyramidal decussation the arrow is marked. So the answer will be contralateral hemiplegia. Is it okay? So the answer will be contralateral hemiplegia. Done? Blood supply of marked structure. Blood supply of marked structure in the given image is derived from which of the following source? Whether the source is internal carotid artery, and whether the source is vertebral artery, whether the source is anterior cerebral artery, or whether the source is middle cerebral artery. So first thing is you have to identify this structure. What structure is this? The first thing is you have to identify. I think you can clearly identify the structure. Which structure is this, my dear students? Firstly, identify the structure. And then you have to mention about the arterial supply of that structure. Blood supply to the marked structure is from which source? Whether ICA, a vertebral artery, anterior cerebral or middle cerebral artery. Yes, absolutely correct. The structure is fornix. Yes, absolutely correct. The structure is fornix. And the blood supply is, what is the correct answer? Not the splenium. Splenium, no dear, not the splenium. Gajendra, if we will see this part is the, if you will see, this is the corpus callosum, no? This is the corpus callosum. So if you go from anterior to posterior, so this whole part is the corpus callosum, and here this will be rostrum of corpus callosum, this will be genu of corpus callosum, this will be body or trunk of corpus callosum, and this posteriorly will be splenium of corpus callosum. This part lower down we will have this part which is lying lower down is definitely the fornix. This is the fornix. So that means the question is about the arterial supply of fornix. Actually in this case also we will have two correct answer, but most correct we have to choose. Actually if I am talking about the arterial supply of fornix, it's mainly from, anyone wants to give the answer? Question number second about the arterial supply of fornix. Anyone wants to give the correct answer? So the most correct I will go with the anterior cerebral artery branch. Actually it is lying on the medial surface of the cerebral hemisphere. Most part of the medial surface of the brain is getting its blood supply from anterior cerebral artery. But if I am talking about the part also originating, then we will have the other source also, that is also taking posterior cerebral artery also. So see here this one. So here fornix is a part of white matter bundle which is receiving blood supply from the branch of anterior spinal artery. Actually anterior cerebral artery, it's a taking blood supply from anterior cerebral artery. So only I have marked anterior cerebral artery as the right answer. But if I am talking about the origin of the fornix, which takes place from hippocampus. So hippocampus is taking its blood supply from anterior choroidal artery and also from the posterior cerebral artery. But if I have to choose more, so major part of fornix is getting its blood supply from anterior cerebral artery, so I will go with anterior cerebral artery. This is definitely fornix. Now, next question. What is the nerve supply of marked structure in the given image? What is the nerve supply of marked structure in the given image? Whether it is third cranial nerve, whether it is the fourth one, whether it is the sixth one, and whether it is the fifth one. Actually, I want everybody, I am enlarging this image. My dear students, I am enlarging this image for you. Please see this and identify the arrow. So actually, you can see this is showing you the extraocular muscles. Okay, this is the eye socket orbit and surrounded by the extraocular muscles. So you have to identify the extraocular muscle and then you have to know about the nerve supply. So just go with the identification of extraocular muscle first and then we will come up with the innervation of the muscles. So actually superior oblique, few of the students are telling superior oblique, actually they are absolutely right. Now the best way to identify is so same image I have taken, yeah. So best way, the best way to identify is that recti is, if we are seeing the anterior view of the orbit and we have to identify the muscle surrounding it. So it becomes easy. Superiorly, this is the lacrimal gland, LG for lacrimal gland. This is superior rectus muscle. This will be the lateral rectus muscle. This will be the medial rectus muscle. This will be the inferior rectus muscle. This is oblique. So this will be the inferior oblique muscle. And the superior most muscle in case of the orbit surrounding, this is LPS muscle. LPS muscle means levator palpebral superioris muscle. And my dear students and my dear friends, this muscle is superior oblique muscle. So what will be this muscle? This is the superior oblique muscle. So we have got the correct identification of the muscle and the nerve supply will be the trochlear nerve. So the fourth cranial nerve is giving innervation to it. So the B is the right answer, and again I would like to give a thumbs up for the students. Very good. Absolutely correct answer, dear. Absolutely correct answer. So we are now knowing that this muscle is superior oblique muscle and we know that LR6SO4, superior rectus, superior oblique by trochlear nerve, lateral rectus by the abducens nerve, and all other muscles, extraocular muscle is supplied by third cranial nerve. Identify the marked structure. Please identify the green color arrow marked structure in this image, whether it is ulnar nerve, whether it is ulnar artery, whether it is radial nerve or radial artery. So I would like to just enlarge this image. So I am enlarging it so that, let me just enlarge. Have a look on this image where you can see the nerves and the arteries, and we will have a green color arrow on one of the nerve. So that will help you to understand which nerve is this. And you can come to the right answer. So I am getting few of the students are giving me the right answer and they are telling unlearn nerve. Again a thumbs up goes for them. Yes, they are absolutely right. They are absolutely right. Unlearn nerve. Actually, this was asked in the as a image based question for the entrance exam of AIIMS. So here what happens, we are, how we are going to identify, we are quite clear. This will be a small pisiform bone which has been shown. This is the palmaris longus tendon. And here this two structure will be the ulnar nerve and ulnar artery. We know the medial most structure is the ulnar nerve. So definitely this thick nerve is the median nerve. So two structures are close together, and we know that medial most structure which is passing superficial to flexor retinaculum is ulnar nerve. So ulnar nerve is the right answer. If you will see this structure, here we will have the pisiform bone. Here we will have, this is an ulnar nerve. Here we will have the ulnar artery. This is the palmaris aponeurosis and this is the palmaris longus tendon. This will be the median nerve, and radially, laterally we will have the radial artery. So the correct answer is ulnar nerve, the medial most structure at the anterior aspect of the wrist. Now I just want everybody, actually one of the question more important is that you have to know the structures passing superficial to flexor retinaculum. What is the other name of flexor? Actually, before coming to this, can anybody tell me which structure, which of the flexor tendons? My question is, which of the flexor, please everyone listen to the question, which of the flexor tendon, flexor forearm tendon muscle is passing neither superficial and nor deep to flexor retinaculum? This muscle tendon is passing in between the flexor retinaculum. My question is, one of the muscle tendon is neither passing superficial nor passing deep to flexor retinaculum. It is passing through the Y slip in between flexor retinaculum. What is the name of that muscle tendon? What is the name of that muscle tendon? Anyone can give me the right answer? Yeah. So anyone? Yes, dear. So the right answer will be, anyone? FDS, no dear, not the right answer. FDS, no. Which muscle tendon is neither passing superficial nor passing deep? This muscle tendon is passing in between the flexor retinaculum or transverse carpal ligament. No, Dr. Lal, Janat, Gajendra, no. The right answer is flexor carpi radialis longus. Actually, this is very important. Just see this image. Can you see the Y color green structure which has been shown in this section? Transverse section is the flexor retinaculum, which is also called as transverse carpal ligament. So we have got many structures which is passing superficial to it. If I am moving from medial to lateral, I am going medial to lateral. The structures are ulnar nerve, ulnar artery, palmar cutaneous branch of ulnar nerve, palmaris longus tendon, palmar cutaneous branch of median nerve. So these five structures are passing superficial to flexor retinaculum, and if you go beneath flexor retinaculum, we have got the median nerve, a very important structure. Compression of median nerve below flexor retinaculum in this space leads to a condition which is called as carpal tunnel syndrome. Now, here the tendons of flexor digitorum profundus and tendons of flexor digitorum superficialis and flexor pollicis longus. These are the four structure which is passing deep to flexor retinaculum. Now, if everybody can see this structure, I am just going to highlight this. This is flexor carpi radialis. Can you appreciate that flexor carpi radialis is passing through the gap of flexor retinaculum? It is passing through the gap of flexor retinaculum. It is neither passing superficial nor passing deep to flexor retinaculum. So what is that tendon? That is FCR. That tendon is FCR. Flexor carpi radialis. Got it? Got it, dear? Got the right answer? Now let's move on to the next. Marked structure in the given specimen is derived from which embryonic structure? Marked structure in the given specimen is derived from which embryonic structures? Whether it is neural crest cells, whether it is bulboventricular flange, whether it is endocardial cushion, or whether it is septum primum. So first thing is that you have to identify this arrow marked area. What is this structure? So basically it's become easy so basically you can clearly see this is the cavity of right ventricle, this will be the cavity of left ventricle, and in between right and left ventricle we have got interventricular septum. And this interventricular septum, this yellow color part is the muscular part of interventricular septum, and this is the upper part. So if I have to choose most correct structure, which is, yes, if I have to choose most correct answer, I will go with endocardial cushion. Let me tell you why. Because you can see here that this is the membranous. If you will see, this is the membranous part of interventricular septum. So this is the membranous part of interventricular septum, and this is the muscular part of interventricular septum. This is the muscular part of interventricular septum. And if I talk about, so you can see interventricular septum is actually bulbar, is having a bulbar part. Bulbar part is continuing with the truncus arteriosus, and together conotruncal arteriosus, which is dividing it, is derived from the neural crest cells. Okay, membranous part and muscular part. That means interventricular septum has got three parts: bulbar, membranous, and muscular part. So if I am talking about the muscular part, it developed from the floor of fourth ventricle, and there is a heaping of muscular ridges which is growing upward from the floor of primitive ventricle, and it will lead to the formation of muscular part of interventricular septum. But the arrow is not on the muscular part of interventricular septum, so we will not mark this as the right answer. Bulbar part, if I talk about, it is developing from bulbar ridges. Okay, it is developing from the bulbar ridges, right and the left bulbar ridges. And if I have to choose most correct, I will go with the bulbar ridges endocardial cushion as the right answer. Bulbar part, which is actually membranous part was marked. So membranous part is derived from the AV cushions and also the part from right and left bulbar ridges. So it is membranous part is actually the part which is deriving from endocardial cushion. If I am talking about the bulbar part, it is from the distal part of bulbus cordis and along with the also by the conotruncal septum together by the neural crest cell. So if I have to choose one, I will go with the endocardial cushion as the most correct answer here. Okay. So I think many of the students has given the right answer. Now, marked tendon is not contributed by which of the following muscle? Actually, this is very important question. And I want everybody just see this image. Just see this red color arrow is on one of the tendon. So you can see red color arrow is on one of the tendon. This is the tendon. So this is which aspect? This is the dorsum. This is the dorsum aspect of the hand. This is palmar and this is the dorsum aspect. And this is the middle finger. This is the dorsum of the middle finger. So this is the extensor tendon. So definitely this is an extensor tendon. Now you have to tell extensor tendon which contribution of the muscle is not taken. Whether it is extensor, so definitely extensor digitorum is not the right answer because extensor hood or extension is formed by extensor digitorum. So this can't be the right answer. Now we have to choose one among lumbricals, palmar introcei and dorsal introcei. Now for understanding this image, briefly I will describe you the muscles, that is lumbricals, palmar and dorsal introcei. Then we will come to the right answer. Many of the students, as actually Alia, Gajendra, Kona, Rick has given the right answer, but you can see this image. So this is the extensor digitorum extension for the middle fingers. Now, if I talk about this, you can see if I am talking about lumbrical muscle, so you can see this is the first, this is the second, this is the third and fourth lumbrical muscle. And if I am talking about this middle finger, you can clearly see the extensor digitorum or extensor hood or extensor extension insertion is taking will be attached in the middle finger, and it will be via the lumbrical muscle. Okay, so definitely lumbrical muscle is attached to the middle finger. If I am talking about palmar introcei muscle, so basically palmar introcei muscle can be 3 or 4, and you can see it is not attached on the middle finger. So if this is the middle finger, you can see in the middle finger extensor extension, the first, second, and third palmar introcei, all palmar introcei are unipinnate muscle, and you can see this all palmar introcei muscle, none of the palmar introcei is attached to the middle finger. So definitely you all are absolutely correct that palmar introcei is absolutely correct answer. So palmar introcei is not attached in the middle finger. Now see the dorsal introcei. You can see there are 4 dorsal introcei, and dorsal introcei attachment is on the middle finger. Definitely you can appreciate that it is on the attachment of the middle finger, and you can clearly see that this is the all dorsal introcei are bipinnate. All the dorsal introcei are bipinnate, and they are attached onto the middle finger. Actually, the action of dorsal introcei can be remembered by a mnemonic DAB. Dorsal introcei is causing abduction. Abduction, if you will write the word abduction, then the spelling will contain AB. So dorsal introcei is causing abduction, and palmar introcei action will be pad. They are causing adduction of the fingers. So that means adduction means moving the fingers towards the middle finger, and abduction means moving the fingers away from the middle finger. So middle finger is taken as the axis on which the palmar and dorsal introcei are acting. Along with this, introcei muscle is also helping with the action of lumbrical muscle, that is flexion at metacarpophalangeal joint and extension at interphalangeal joint. So if I have to choose one answer, I will definitely go with palmar introcei is the right answer. All others are contributing to the extensor insertion in extensor hood, extensor insertion, but not the palmar introcei muscle. Coming to the next one, that is actually, yes, same thing, extensor digitorum, and taking the contribution from introcei muscles, dorsal introcei, but not the palmar introcei. Now the next question is, marked area is related to which of the following structures? So you can see green color area is marked on one of the kidney, and you have to, this is the anterior view of the kidney. This is the anterior view of the kidney. You have to tell about the anterior relation of right and left kidney. The first thing is you have to identify that whether it is right kidney or whether it is left kidney. So the first thing which you have to go through this image is identification of right and the left kidney. And that hint is provided by the presence of adrenal glands, and also inferior vena cava is there, which will give you a hint of identification of right and the left kidney. After that, you have to know that on the anterior aspect of the kidney, which structure is related on this arrow marked area. So please mark the right answer. So all of you, okay, so I got an answer. One of the student is telling stomach, okay, stomach, other is telling spleen. So, and one is telling second part of duodenum. Oh, multiple questions are coming up. So multiple answers are coming up, and I have to come up with the most correct answer. So multiple answers are coming up, and I have to come up with the most correct answer. My dear students, okay, no worries, I will tell you. Actually, the correct answer is spleen. Those who have given spleen as the right answer, they are correct. They are correct. Now, let me tell you how. Okay, let me tell you how. The first thing is that this, if you will see, this is triangular. This is a triangular in shape. So, this is right adrenal gland. This is right adrenal gland, and this is semilunar cap. This is left adrenal gland. Also, in this diagram, you can appreciate this is inferior vena cava. Okay, this is inferior vena cava. So definitely inferior vena, right kidney. So definitely if I talk about inferior vena cava, this is close to right kidney. So this is right kidney and this is the left kidney. Now the arrow is marked on left kidney. Now this is known that the arrow is marked on the left kidney on the lateral anterior aspect, upper lateral aspect. Okay. Yes, Janet, the spleen is the right answer. So now we are knowing this is the left kidney. Now you can see if I am talking about the relations of the kidneys on relations of anterior aspect of both kidneys. So we can see here that the duodenum, liver, suprarenal gland, colic plexus are related to the right anterior aspect, and this part is related to the spleen. Stomach will be slightly more medial to the spleen, and this is the pancreas in the middle area, and coils of jejunum and the left colic plexus. So if I have to go with most correct area, it will be the spleen. It will be the spleen. So definitely liver is not the right answer. Why not liver? Because liver and duodenum is related to the right side. Stomach is also not, because it will be more towards the upper medial aspect, and the most correct answer is spleen. Most correct answer is spleen. Is it okay? Let's move on to the next question. Injury to the marked nerve will cause. So again, this is a cadaveric image question in which you have to identify the red arrow marked structure. So we will come to the option afterwards. Firstly, I will enlarge this image. Why enlarging it? So that you can get a clear view of this image. Can you see this is the area of cubital fossa, anterior aspect. You can appreciate the structures here and identify the red color arrow marked structure. Yes, Janet, all relations are important. Yes, Janet. Also, posterior relation are also important for kidney. If you want, I can tell you, posteriorly, the relation of kidneys are more or less similar on right and left side. It is related posteriorly by the subcostal nerves and the vessels, the ilio-hypogastric nerve, the ilio-inguinal nerve, the psoas major muscle, okay, and also by the other muscles like a quadratus, also by the transverse abdominis, quadratus lumborum, and also by the 12th and 11th rib on the left side, and only 12th rib on the right hand side, because there is a liver on the right hand side. So yes, so basically red color arrow, which structure is this? So Rasta Mirza has given the right answer, but I just want, what is the red color arrow mark structure? What is that? Which nerve is this? Yes, the structures related from medial to lateral will be, so if this will be the medial side and this will be the lateral side. Yes. So Gajendra median, okay. So here actually this is an extension. So if you will see, this is an extension from the biceps tendon. So I will come with the explanation of these identifications of the structures, and this is one of the tendon. So see here. So basically here, if I have to come, this structure will be bicipital aponeurosis. So bicipital aponeurosis is actually an extension from the biceps tendon on the medial side, and this bicipital, if I am talking about this bicipital aponeurosis, this is going medially and this will be forming the roof, which is running over, and this is biceps tendon. So if I go to the medial most structure, this structure is median nerve. This is the first structure M. This structure which you are seeing, I will use red color for it. This will be the brachial artery. This will be the median nerve, and this is also a nerve. So this is the first structure. This will be the second structure. This is brachial artery, BA for brachial artery. And this structure will be the biceps tendon. This is the biceps tendon, which is the third structure. This is the third structure, and this is the fourth structure, which has been arrow mark structure. This is the radial nerve. Actually, radial nerve and this level is dividing into two structural extension. Superficial will go laterally towards the roof of anatomical snuff box, and the deep branch of radial nerve, that is posterior introosseous nerve, will pierce the supinator muscle. Now we are quite clear that the red color arrow mark structure is the radial nerve. So the deformity which will be seen in this case will be wrist drop. Yes, Janet, how to identify medial and lateral side? I will tell you how. Basically, yes, Janet, sometimes aponeurosis is also removed. Actually, if you will see the cubital fossa, by seeing this region, you can clearly see that this is a region of cubital fossa. The one of the important structure which by seeing only you can identify is the biceps tendon and bicipital aponeurosis. So this will be the biceps tendon. Now you can see an artery and nerve are going together. Actually, also you can see in this diagram that this is the pronator teres muscle, this is the brachioradialis muscle. So this will be the pronator teres, so this will be the medial side. So this becomes the medial side and this becomes the lateral side. Okay, and other than that, two structures are running very close medially, and we know that always the artery and the nerve are two structures which is running close to it. So this will be the medial nerve and the brachial artery. So this two structure will be the medial nerve and brachial artery, and this will be the lateral side structure, and this will be the radial nerve, and this is particularly the biceps tendon. This is the biceps tendon. So this is the third structure and this is the aponeurosis. Is it okay? Now the next question. Yes, brachial artery, you can clearly see brachial artery and medial nerve will be covered by bicipital aponeurosis, and this pronator teres and brachioradius. Actually, you can see also the biceps tendon, and close to it will be only one nerve, so that is radial nerve, that will be on the lateral side. But on medial to biceps tendon, we will have two important structures, that is nerve and artery. Now, which of the following structure, let's move on to the next one. Which of the following structure is not supplying the marked area of the heart? So in between I can stand also at times, just a minute for a few seconds. Is it okay? Yeah. Okay, just a minute. I think that is, yeah, I will sit only. So if you want, I can just show you this image. So you have to firstly identify this arrow marked area. So please identify this arrow marked area of the heart. This arrow, black color arrow marked area of the heart. So which chamber of the heart is this? And then tell me which of the following is not supplying arterial supply to this area of the heart. Okay, anyone? Right ventricle, absolutely correct. This arrow marked area is right ventricle. Yes, right ventricle. So which artery? So we know that we have got right coronary artery, left coronary. The branches of right and left coronary artery will give blood supply to both the ventricles also. So right ventricle is a ventricular chamber which is receiving blood supply from branches of both right and left coronary. But there is one artery which is basically giving blood supply only to left ventricle. You have to identify that artery. There is one artery which is basically giving blood supply only to the left ventricle of the heart. So you have to identify that artery, whether it is right coronary, whether it is anterior interventricular, marginal or diagonal artery. Actually, a correct answer is coming from my dear Alia, Janet, and so proud of you. Very good, Kona. Everyone, so good. This was a very good question, and a correct answer is coming up from these students. Yes, diagonal artery. A thumbs up goes for you. Yes, absolutely right. Diagonal artery is a branch from left coronary artery, and this artery is giving blood supply only to the left ventricle. So you can get an idea from this image. So see this image. Here you can see this is the left ventricle. This is forming the apex of the heart that is formed by left ventricle, and you can see here if you will see the diagonal artery, this is the diagonal branch. So see here, this is the diagonal This is the diagonal branch or the diagonal artery, which is a branch from the left coronary artery, which is basically giving blood supply only to the left ventricle. The other branches, left circumflex, left anterior descending, which is also going and which is also supplying left ventricle and right ventricle. Also the branches like posterior interventricular, posterior descending right coronary artery will also give blood supply to the right ventricle and right atrium. So basically only diagonal artery is a artery which is a branch of left coronary artery which is giving blood supply only to the left ventricular chamber of the heart. Now, my dear, please identify the marked layer in the given histological slide. So, I will tell you this is a histological slide of retina. So, this is a histology question and you can tell me, yes, marginal artery, yes, Dr. K lecture, marginal artery is a branch from right coronary artery given as from a branch from left and they are giving blood supply to both the right ventricle also. Identify the marked layer in the given histological slide. So this histological slide is of retina. This is of retina. So I just want you to identify the green color layer of, I just want everyone to identify the green color layer. Also just a minute. Please identify the green color layer. Identify the marked layer in the given histological slide. So yes, few answers are coming up, inner plexiform and all. I want to say, I'll show you the same image with the identification of the layers of the retina as you proceed from the choroid structure. So one of the layer is very easy to identify, then you can go continuously with the next layer. So here, if you will see this diagram, what you can see that this is the retinal pigment layer. This will be the retinal pigment layer, which is pigment retinal layer is which type of epithelium. So if you will see closely, you can identify this is cuboidal. This is simple cuboidal epithelium. So very nicely you can appreciate this layer. So if you identify this, then you can continuously go upwards and towards the source of light. So this is actually simple cuboidal epithelium. Simple cuboidal epithelium. Then we have got the layers of rods and cones, which is also identified. Then we have got the nuclear layer, plexiform layer. Then we will have firstly the outer nuclear and outer plexiform layer, the synaptic layer, then the inner nuclear and inner plexiform layer, and next is the ganglionic layer and the axons of ganglionic cells forming inner fiber membrane and inner limiting membrane towards the light source. So definitely the correct answer will be inner plexiform layer. So in this case, we will have the right answer, that is inner plexiform layer. Layers of rods and cones are easy to identify and pigment layer will be the first to be identified because of the shape, that is the pigment layer of the retina because of the shape, because it is simple cuboidal epithelium. Then layers of rods and cones, inner nuclear, inner plexiform, outer nuclear and the inner plexiform layer is the right answer. So you can just go through this image where the retinal layers has been shown and you can revise all the layers of the retina. Now this is an easy one. This is an easy one. Which of the following part of brachial plexus does not give any branch? Yes, Janet, you are right. Retinal pigment epithelium. Which part of brachial plexus does not give branch? Division, absolutely correct. Yes, if I talk about the brachial plexus, it has got roots, it has got trunks. If we talk about the components of brachial plexus, it is having roots, it is having trunks, it is having division, it is having cords. So basically roots are giving branches, it is giving LTN and dorsal scapular nerve. Trunks may, upper trunk is giving SS and NS, that is suprascapular and nerve to subclavius. Cords, we have got 3 cords and we know that all the 3 cords are giving branches. All the 3 cords are giving branches. We have got branches from lateral, medial, and the posterior cord. So I think everybody is knowing the branches of cords of brachial plexus. If you want, I will tell you a story for it and mnemonic, and you can understand the branches of the cords of brachial plexus. The division, actually roots are formed by the ventral rami of C5, C6, C7, C8 and T1. So if you will see this diagram, you can see this is the roots. This is showing the roots of brachial plexus, BP for brachial plexus, and roots are formed by C5, C6, C7, C8 and T1. This is the most common formation. Can anybody tell me, sometimes there can be prefixed brachial plexus and sometimes there is post-fixed brachial plexus. Can anybody tell me prefixed brachial plexus is taking contribution from which nerve root? Yes, I will tell you, Janet. Prefixed. So what is happening this? Okay. Prefix. So you have to tell me which is the prefixed brachial plexus and which is the post-fixed brachial plexus. So if I am talking about prefixed brachial plexus, it is taking, yes, absolutely, Dr. K lectures and Janet, yes, it takes contribution from C4 and C4 and post-fix is taking contribution from T4. Absolutely right. Ravi, Hindi में, okay. Prefix brachial plexus C4 से contribution भी ले सकता है और postfix T2 से contribution ले सकता है. T2, this is T2 please. This is T2. Sometimes, okay. Now, from the roots of brachial plexus, we will have only two branches, that is dorsal scapular nerve and long thoracic nerve. Dorsal scapular nerve and that of long thoracic nerve. Now, from the trunks, it is good point that only upper trunk is giving branches, and from upper trunk we have got two important branches most of the time, suprascapular nerve and nerve to subclavius. Actually, 1 hour more, Shiv Kumar, 1 hour more. Are all of you are getting tired? Please let me know. 1 hour more, I think. Is it okay, everyone? Minimum 1 hour more, minimum 1 hour more, I think. Is it okay, Shiv Kumar, everyone? So we have got two branches, nerve to subclavius and suprascapular. Now this C5 and CT will join to form the upper trunk, C7 will form the middle trunk, and C8 and T1 will form the lower trunk. Now each of this is dividing into division and there is no branches from the division. There is no branches from the division. Okay. Now, if I talk about the cords, we have got three cords. We have got lateral cord, we have got posterior cord, and we have got a medial cord. Now, what happens, for example, to understand the branches of the cords of brachial plexus, I would tell you a story. For example, when you want leave, when you want to apply leave, what you do? If you want leave, you will tell your teachers, or in medical college, yes, I want a leave, and you will get it. Sometimes it doesn't happen, so you will tell that you want a medical leave too. You want to meet someone special, so you will tell your teacher that you want a medical leave too. How many? Medical leave too. Medical leave too. So that means branches of lateral cord, medical leave too, ML2. So that means three branches, M for musculocutaneous nerve, L for lateral pectoral nerve, and another L for lateral root of median nerve. So just see here. So here, branches of lateral cord, branches of lateral cord. अगर आपको किसी से मिलना है, अपने फ्रेंड से मिलना है और आपको अप्लाई करना है, क्या अप्लाई करना है? लीव अप्लाई करना है, तो आप क्या करोगे? आप मेडिकल लीव के लिए अप्लाई करोगे. कितने मेडिकल लीव के लिए अप्लाई करोगे? 2 मेडिकल लीव के लिए अप्लाई करोगे. मेडिकल लीव 2. And the branches from the lateral cord will be ML2. Here M stands for musculocutaneous nerve. Musculocutaneous nerve. Another is lateral pectoral nerve, and other is the lateral root of median nerve. Lateral root of median nerve. Now after that, branches of posterior cord. If I am talking about the branches of posterior cord, the mnemonic is rats in the upper self and rats in the lower self. Now you want that special person to invite at your place, so you have not cleaned आपने अपनी घर के सफाई बहुत दिनों से नहीं की है, so you have to clean your room for that special guest at your place, your special friend. So when you were cleaning your room, what happened? You found rats in the upper and the lower cells. So the branches from posterior cord is 5, branches from lateral cord is 3, branches from posterior cord is 5, and that are R for radial nerve, A for axillary nerve, T for thoracodorsal, S for upper and lower subscapular, US upper subscapular, LS lower subscapular. ठीक है? Now coming to medial cord. Now after that special person at your place, you told, when that special person came to your place, you told him or her, me for you, me for you, made for each other, like me for you. So here also 5 branches, and M, 4M for medial cutaneous nerve of arm, medial cutaneous nerve of forearm, medial pectoral nerve, medial root of median nerve, and U for ulnar nerve. That means branches of lateral cord, ML2, medial leaf 2, musculocutaneous, lateral pectoral nerve, and lateral root of median nerve. Posterior cord, cleaning in the room, rats in the upper and the lower cell, rats, radial nerve, axillary nerve, thoracodorsal, that is the upper subscapular and lower subscapular. Medial cord branches, me for you, 4M and 1U, U for ulnar nerve, and 4M for medial root of median nerve, medial pectoral nerve, medial cutaneous nerve of arm and forearm. Got it? Got it, everyone? Now coming to next question, that is, which of the following structure crosses the marked area? Which of the following structure crosses the marked area? So basically you have to identify this red color arrow marked area. Is it okay, everyone? This is red color arrow a structure. This is red color arrow marked structure. So you have to just identify this red color arrow marked structure. Okay, dear. This structure you have to identify. Can anybody tell me the name of this structure? Can anybody tell me the name of this structure? Yes, yes, Dr. K. Dr. K, you are absolutely right, dear. You are absolutely right. Yes, this is an ischial spine. Absolutely correct, dear. This is ischial spine. Now, ischial spine is dorsally related by 3 important structure, and now you can tell me that which of the following structures is crossing the marked structure, ischial spine. Whether it is obturator nerve, whether it is sciatic, whether it is pudendal, whether it is inferior rectal nerve. Okay, pudendal nerve is absolutely correct answer, dear students. Yes, we know that dorsal aspect of the spine is crossed by pin structure. Pudendal nerve, internal pudendal vessel, and N for nerve to obturator internal. So definitely on the dorsal aspect of ischial spine, we will have the pudendal nerve. So this is ischial spine and the structure will be pudendal nerve. And I just want that everybody should by heart the structures passing through greater and lesser sciatic foramen. So many times this question has been asked. So basically we have got actually where the structures crossing to the greater sciatic foramen, we will see, we generally tell piriformis muscle as the key muscle of the gluteal region. Piriformis muscle is the key muscle of gluteal region. So why? Because we have to identify when we go for dissection, what happens? We will clean the whole area, and then we will see that few of the structures passes above piriformis muscle and few of the structures passes below piriformis muscle. So we will have superior gluteal nerves and vessels passing above the piriformis muscle. We will have inferior gluteal nerves and vessels, sciatic nerve, posterior cutaneous nerve of thigh, perforating nerve, pudendal nerve, internal pudendal vessel, nerve to quadratus femoris, nerve to obturator internus, and 4 of the structure will then pass in the lesser sciatic foramen. In this, pin structure will be related on the dorsal aspect of the ischial spine. that is PIN, pudendal, internopudendal vessel, nerve to obturator internus and tendon of obturator internus muscle. So just have a quick revision of this. Now the next question is, this is actually in the AIMS entrance exam, they have asked about few questions, two more questions from the, two questions exactly in one examination from the cubital region. Injury to the marked nerve can cause, injury to the marked nerve can cause A, loss of sensation over hypothenar muscle, loss of sensation over the dorsum of the little finger, loss of sensation on the nail of the index finger, loss of sensation on the fourth interdigital cleft. The first thing is that I have already explained this image. I want everybody to identify this nerve. So first thing is that you have to identify this structure. So which is this structure, dear? Which is this structure? So firstly identify the structure. So I think most of you will be able to identify because we have already discussed this cadaveric image. Then identify the structure. Then identify the structure and then identify this structure also. Okay, so we have got this arrow. So very nicely we can see this arrow is on median nerve. This is brachial artery. This is biceps tendon. Yes, and this is radial nerve. So I got the right answer from Janet, and Janet is absolutely right. The loss of sensation on the nail of index finger. So we know that on the dorsum aspect of the hand, index finger dorsal nail buds are getting innervation from the median. We know that median nerve is giving innervation to the lateral aspect of the palm and also on the lateral 3.5 nail buds. Okay, so we know that the arrow marked structure is median nerve. So loss of sensation on nail of index finger. Loss of sensation over hypothenar is not the right answer because that will be due to ulnar nerve. Sensation on dorsal aspect of the little finger is also not, that will be via ulnar nerve. Sensation on fourth interdigital cleft is also not, that will be also ulnar nerve. We will have the right answer as the nail of index finger. So just a quick revision, you can see this image and you can identify the dorsal and the ventral aspect nerve supply. So we can see dorsal aspect, the nail buds are getting innervation from median nerve. This is the area of distribution of ulnar nerve, both on palmar and dorsal aspect, medial 1.5 of the palm and medial 1.5 of the fingers by ulnar nerve, and rest area on the palmar aspect laterally is supplied by median nerve, and this is the area of radial nerve innervation on the dorsal aspect. Now NEET PG 2020 MCQs also, NEET PGs and also few MCQs quickly we will solve. Then we will go to INICET also, because why I am going through this, because sometimes the few of the NEET PG's question is also discussed, because sometimes the question comes from, for your INICET also pay attention to INICET MCQs also NEET PG, for your NEET PG also pay attention to INICET exam question. So this is very easy one, that meiosis occurs in prepubertal testis, ovary, adrenal or hypothalamus. Ovary, absolutely right. Prepubertal testis is there, so it is wrong. It should be pubertal testes. Yes, it should be pubertal testis. Absolutely correct. Yes, I think everybody is knowing it. Also, you can see the primordial germ cell goes with the primary, goes with the formation of ogonium, enlarges with the process of mitosis. Then primary oocyte, and primary oocyte will go to the, yes, Janet, you are right. Actually, the process of oogenesis starts in female before birth only, but it get completed once the ovulation start. The first meiotic division is completed. Second meiotic division is completed only when the fertilization occurs. Identify the type of cartilage. whether it is elastic cartilage, hyaline cartilage, fibro cartilage or articular cartilage. Identify the cartilage. So I am getting mixed answer. Hyaline is also coming up. Hyaline, fibro. So that means cartilage revision is necessary for you. Cartilage revision is necessary for you. Actually, this is a histological slide of one type of cartilage, and how we are going to identify, I will tell you. So my dears, no one has given me the right answer till now. None of you have given me the right answer. That means cartilage has to be revised. See here. Actually, when I will explain first, all of you, let me first explain you. If I talk about hyaline cartilage, it is of two varieties. One is the costal variety and the other is articular variety. Now, the costal variety of hyaline cartilage will have cell nest and will have the presence of perichondrium. So, perichondrium is present and the chondrocytes, if you will see the chondrocytes are arranged in group. So, this is P for perichondrium. P for perichondrium, which is having two layers, outer fibrous and inner cellular layer. Also, what you can appreciate, there is ground substance, there is chondrocytes, and these chondrocytes, cells of cartilage is called as chondrocytes, and these chondrocytes are arranged in group that is called as cell nest. What is it called as? They are called as cell nest. Okay. Elastic cartilage, there is large number of chondrocytes. So, large number of chondrocytes, and in between elastic fibers are also there. So, perichondrium is also there. There is also presence of elastic fibers in the matrix. If you will see this image, what you can see, the number of chondrocytes, the chondrocytes are large in number. So, the chondrocytes are much more in number, and if you will clearly see this image, what you can see, that these in between, you can see these are elastic fibers which are running. So, it is brightly stained, and these fibers which is branching and singly running, these fibers are elastic fibers. So, there is elastic fibers also. These will be the part of perichondrium chondrogenic layer, and the whole slide is stuffed with so many numbers of chondrocytes, brightly stained, and definitely the right answer is the elastic cartilage. The right answer is the elastic cartilage. Now, here we will have the fibrocartilage. The third variety is fibrocartilage, which will have a collagen fibers. So, if you will see the appearance of fibrocartilage, it will have collagen fibers, and that collagen fibers will have a wavy appearance. Nucleus of chondrocyte. So, you can see the chondrocyte nucleus has been shown, and these chondrocytes are lying in the lacunae. Row of chondrocytes are running, and collagen fibers are there. Okay, there is no perichondrium. There is absence of perichondrium. Also, one of an important. So, exactly if I talk about this cartilage, so fibrocartilage is having less number of chondrocytes. Fibrocartilage is having less number of chondrocytes, and there is no perichondrium present, and there is type 1 collagen fibers. If I talk about hyaline cartilage, costal variety, and also if I talk about elastic cartilage, they are containing type 2 collagen fibers. Okay. So, basically, if I have to choose, I will go with right answer, that is elastic cartilage. Is it okay, everyone? Now, coming to the next one, that is the next question. Okay. So, dear students, don't worry, your Aswani sir, yes, you are right. He has gone for a short trip, so only I am taking this session for you. So, he will return and he will definitely get connected by you. Okay, don't worry. So, now identify. Yes, Kona, you are right. Type 1 collagen fibers are present in fibrocartilage. Type 1 collagen fibers are present in fibrocartilage. All other elastic and hyaline cartilage will have type 2 collagen fibers. Now, identify the arrow mark structure. So the flask-shaped arrow mark structure. So you have to identify very nicely. You can see the shape is, what is the shape? This is Purkinje or flask-shaped cell structures. These are flask. These are flask-shaped cells, and these are Purkinje cells. Absolutely right answer is given by most of the students, and they are absolutely right. These are Purkinje cells. So these are Purkinje cell dendrites, and these are actually Purkinje cells. These are actually Purkinje cell bodies. And deeper aspect, actually we will have three layers in the cerebellum. If I talk about the cerebellum cortex histology, we will have three. We will have an outer molecular layer. So there is an outer molecular layer, the most superficial one. Then we have got Purkinje cell layer, and the third is the granular layer. So most inner side we will have the granular layer. We will have the granular layer, which is containing the granule cells. So see here, this is the molecular layer, then Purkinje cell layer, and the inner aspect is having the granular layer. All the cells, we will have Purkinje cells, we will have granular cells, we have got stellate cells, we will have Golgi cells, we will have Purkinje cells. All the cells are inhibitory, but except the granule cells, which are excitatory in nature. Left recurrent laryngeal nerve has got a comparatively longer course due to the persistence of which pharyngeal artery? Due to the persistence of which pharyngeal artery? So yes, absolutely right answer. It's the sixth pharyngeal artery. Actually, left recurrent laryngeal nerve, if you will compare the course, left recurrent laryngeal nerve is having longer course as the right recurrent laryngeal. The reason is persistence of ductus arteriosus in the left hand side, and this ductus arteriosus will become in adult ligamentum arteriosum. So that is the right left recurrent laryngeal nerve wind around ligamentum arteriosum, and you can see this ductus arterios lies, and this is the left recurrent laryngeal nerve winding around that. So only we have got longer course of recurrent laryngeal nerve on the left hand side. Now type of joint marked by the arrow. So tell me type of joint which is marked by this arrow. Whether the type of joint is syndesmosis, whether the type of joint is synarthrosis, whether the type of joint is symphysis, and whether the type of joint is synovial joint. Type of joint marked by the arrow. So yes dear. So can you tell me the name of this joint? What is the name of this joint? So we have got one joint here and we have got one joint here. So can you tell me the name of joint? It is which type of joint? So actually the arrow mark joint is costo. Yes, you are right, Pihu. That was the earlier question. Yes, Pihu, you are right. Now this joint is costo-transverse joint, and this is costo-vertebral joint. This is costo-vertebral joint. So we have got costo-transverse and costo-vertebral joint. So if I have go to most correct answer, it is plain type of synovial joint. And yes, absolutely a thumbs up goes for Rahil Abbas. Rahil Abbas has given absolutely right answer. Yes, it is a costo-transverse joint of plain type of synovial joint. So here you can see actually when you will see the articulation which is taking place, if you see the articulation here, you can see the articulation of the ribs is taking place at two parts in the vertebra. So one is costo-transverse joint and the other is costo-vertebral joint. So if the articulation of costo-transverse joint we talk, so this is type of plain type of synovial joint. So which type? It is plain type of synovial joint. So definitely this is the right answer. Yes dear. Now coming to the next question, question number 8, nerve supply of muscles shown in the diagram. So firstly, I want everybody to identify this muscle. All of you please identify this muscle. So first thing is identification of this muscle and then tell me the nerve supply. So firstly, identify this muscle. Which muscle is this? And then tell me the nerve supply. What is the nerve supply of this muscle? Nerve supply of the muscles shown in the diagram. Whether it is suprascapular, dorsal scapular, the subscapular, the dorsal rami of the C1. My dear students, I have taken 2021 question, 22, 23 and 24 also. I think I will take 1 hour more. Is it okay for you? Please let me know. Minimum 1 hour more, minimum 1 hour more, because I have got 3, 4, 5 papers more. So quickly we will solve it, but it will be a great help for you. The right answer is, yes, the right muscle is levator scapulae. Yes, absolutely correct answer, my dear students. This is levator scapulae. So yes, the levator scapulae is absolutely the right identification of this muscle, which is attached onto the medial border dorsal aspect of the scapula from the superior angle till the level of the spine of scapula. This is the spine of scapula. So here we will have the levator scapulae muscle. Then we will have the rhomboidus minor muscle, and lower to it here will be the rhomboidus major muscle attached. So here if I talk about the nerve supply, it is via dorsal scapular nerve. Dorsal scapular nerve is absolutely right answer. Yes. So here we will have levator scapulae muscle, which is originating from C1. So please have a look on the attachment of levator scapulae muscle. So this is the C1, C2, C3 and C4, which is the levator scapulae muscle, which is attached here, and its insertion is onto the superior angle dorsal aspect of the spine of scapula. And the nerve supply is dorsal scapular nerve. Dorsal scapular nerve, that is the right answer. Is it okay, everyone? So Rahil Abbas is telling it's okay, you can take 1 hour more, maybe 1 hour more or 1 hour 10 minutes. Is it okay? Can you be live for till all the questions will be done? You tell me if it is okay, then I will continue. Okay, little bit fast, ma'am. Okay, sure. Why not? Little bit fast. Okay, why not? Yes. So Kona is telling little bit fast. Okay, we can be a little bit fast. Yes, absolutely fine, Kona. Hand deformity presenting hyperextension of metacarpophalangeal joint and flexion at interphalangeal joint occurs due to the paralysis of which of the following muscle? Okay, flexor digitorum profundus, lumbricals introsei and extensor digitorum. 4 options are there. The hand deformity which is presenting hyperextension at the metacarpophalangeal joint and flexion at the interphalangeal joint occurs due to the paralysis of which of the following muscle? Flexor digitorum profundus, lumbricals and the introsei and the extensor digitorum. So most correct answer. So Kona is telling B. Okay. And I have got KP who is telling C. So I want most correct answer. Still the right answer I have not received, means I have received. So actually I will tell you the most correct answer. Actually let me explain it. Okay. The most correct answer is lumbricals and introsei muscle. So that is given by KP, and KP, a thumbs up is for you. KP, a thumbs up is for you. So you are absolutely right. I will tell you how. Why lumbricals? Actually, the correct answer is lumbricals, but I will tell you why introsei also. Basically, the action of lumbricals, understand, the action of lumbrical muscle is this: flexion at metacarpophalangeal joint and extension at interphalangeal joint. But the reverse happens in the claw hand. So when you will see the claw hand, there is paralysis of lumbrical muscle. We know that medial lumbricals is supplied by ulnar nerve and lateral lumbrical muscle is supplied by medial nerve. So when there is both injury of median and ulnar nerve, that means complete paralysis of lumbricals happen, and the patient will have claw hand like this, that is just the reverse of the action of lumbricals. That means here the person will have the extension at metacarpophalangeal joint and flexion at interphalangeal joint. See this image. So there is extension at extension at metacarpophalangeal joint and flexion at interphalangeal joint. This is the action, just reverse the lumbrical muscle. As I told you, the primary action of introsei muscle is pad and dab. Palmar introsi, adduction of finger, dorsal introsi, abduction of fingers. But other than that, they also help in the action of lumbrical muscle. So if I have to choose the best possible answer, I will go with lumbricals and introsi muscle. Lumbricals and introsi muscle. See here, this is exactly the action. So this is exactly the action of lumbrical muscle, and just the reverse of it will be the, this is the action of lumbrical muscle, but just the reverse of it will happen in the claw hand. Okay, reverse of this in the claw hand. In claw hand, there will be flexion at interphalangeal joint and extension at metacarpophalangeal joint. Yes, you are right that palmar introsia is causing pad and dorsal introsia is causing dab as the action, that is abduction and adduction of fingers. But other than that, introsia is also helping in the action of lumbrical muscle. So the accessory action of introsia muscle is also involved in the action of lumbrical muscle. So that means if I am talking about introsia muscle, they are also associated with the accessory action of lumbrical muscle. So if I have to choose one, I will go with lumbrical and introsia muscle. Is it okay, Kona? Is it okay, Kona? So that is the reason we will go with this C, lumbricals and introsia muscle as the right answer. Everyone is okay with this? Can we go to the next question? Everyone okay? Can we go with the next question? Kona, please tell me, and please tell me about my pace also. Is it okay? Okay, my pace is okay because Pihu, thank you so much, dear. Thanks, dear. Thanks. Thanks, dear. Now, ligation of common hepatic artery will compromise blood flow in which of the following arteries? Ligation of common hepatic artery will compromise the blood flow in right and the left gastric arteries, right gastric and short gastric arteries, right gastroepiploic artery and short gastric artery, right gastric and right gastroepiploic artery. Ligation of common hepatic artery will compromise blood flow in which of the following arteries? So, I got Rasta, Mirja, Thala, Pathi. I got, so actually absolutely correct answer, Pihu and everyone, KP. Yes, you are right. The correct answer is D, and the reason is that, yes, absolutely correct answer is the D, because both of these are branches from the hepatic artery, common hepatic artery. So, both of these are the branches from the common hepatic artery. Yes, absolutely right. Right, and so left gastric artery is a direct branch of celiac trunk, so it is wrong. Short gastric artery is a branch from splenic artery, so it will be not affected. And right gastroepiploic artery and short gastric artery is again not the right answer, because right gastroepiploic artery is again a splenic artery, so it is not the right answer. So we will go with right gastric artery and right gastroepiploic as the right answer. Now see this diagram. Here you can see that common hepatic artery, we have got three direct branches from the celiac trunk, that is left gastric artery, common hepatic artery, and we will have the splenic artery. Now here common hepatic artery further gives proper hepatic artery. It gives a branch that is gastroduodenal artery, which gives right gastroepiploic artery, and it also gives right gastric artery. So basically the origin of right gastric artery and right gastroepiploic artery is from the source of common hepatic artery, so that will be affected. So absolutely the right answer will be D. Is it okay, everyone? Understood? Basically right gastric artery is a branch from source of common hepatic artery, also right gastroepiploic, which is a branch from gastroduodenal, which is again having the source from common hepatic artery. So these two arteries will be affected, but other arteries being a direct branch of celiac trunk or branch of splenic artery will not be affected. Okay, now coming to the next question, that is question number 11. Question number 11, a 56-year, this is a clinical question, a 56-year-old man comes to the hospital with abdominal pain, jaundice, loss of appetite and weight loss.
On examination done on his radiogram and CT scan, a physician finds a growing tumor in the uncinate process of the pancreas. Which of the following is most likely compressed in this case, whether it is the splenic artery, whether it is the portal vein, whether it is superior mesenteric artery or superior pancreatico-duodenal artery. So we will have 4 options and you have to mark the right answer. So I got Thalapathy has given the answer, Pihu has given, and both of them has given again a great answer. Superior mesenteric artery is the right answer. Who has given this? This is wrong. Superior mesenteric. So who have given the C? I only told the answer. Superior mesenteric artery. Ayush, go ahead. I only tell you the answer. Okay, no, superior pancreatico-duodenal will be not the right answer. Superior mesenteric vessel. Actually, uncinate process of pancreas, the tumor, and if it is, it will compress in superior mesenteric vessel. So please see this option. See this image. Everyone, so few of you have marked it wrong. So yes, so please have a look. This is U for uncinate process. This is head. This is the body, and this is the tail. Now you can see this is the pancreas. So can you see superior mesenteric vessel is related with uncinate process. So superior if the uncinate process will enlarge. Now see this diagram showing the relation. So uncinate process is enlarged. Which structure will be compressed? Superior mesenteric vessel. Is it okay to everyone? Most of you have marked the wrong answer. Is it okay? If uncinate process is enlarged, uncinate process of pancreas, it can compress the superior mesenteric artery and the vein which is closely related with the uncinate process. So we'll mark this C as the right answer. Everyone, yes, Gautam is right here. Everyone, is it okay? Clear? Clear, everyone? Remnants of Wolffian duct in the females are found in which area? Remnants of Wolffian duct in females are found in which of the following area? Whether it is pouch of Douglas, whether it is utrovesical pouch, whether it is broad ligament, whether it is iliac fossa. So definitely the right answer is broad ligament. Yes, we know that remnants of Wolffian duct is found in the broad ligament of the uterus, which is giving secondary support, not the primary support, but the secondary support to the uterus. Yes, that is the right answer. Actually, in females, the remnants of Wolffian duct is found in the location of broad ligament. So remnants of Wolffian duct is in the form of epiphoron, is in the form of Gartner's ducts and cyst, and these are the structures which is located in the broad ligament, which is again having 4 parts. We know broad ligament is hanging from the sides, giving secondary support to the uterus, and it is having mesoovarium, it is having mesosalpinx, mesometrium, and also the suspensory ligament. So these are the 4 parts of broad ligament, and we have got many structures in the layers of broad ligament, and we have got the Gartner's, we have got the Wolffian duct remnants also. Now let's come to the next question. Okay. Everyone, my pace is okay. Please let me know, my dear students, my pace is okay. Am I going very fast or very slow? A man is brought to the emergency. Yes, absolutely right, Pihu. A thumbs up goes for you. Absolutely right, Pihu. A man is brought to the emergency department after meeting with an accident and has injured the perineum. He feels an urge to micturate but is unable to pass the urine, and there is blood at the tip of the meatus with extensive swelling of the penis and the scrotum. Okay, thank you, dear. It's okay, then that is great. Yes, so there is involvement, there is extensive swelling of the penis and the scrotum. So you have to tell me the possible site of injury, whether it is penile urethra, whether it is bulbar urethra, whether it is membranous urethra or urinary bladder. So I am getting C also, I am getting B also as the right answer. Actually, the most correct answer I will tell you. Actually, whenever there is an injury and there is a collection of fluid urine in the area of the around the scrotum and all, and the most common injury is the bulbar urethra. So we'll mark bulbar urethra as the right answer. Membranous urethra will be the answer where there is deep extravasation of the urine when there is injury of the membranous. When there is membranous part of urethra injured, there will be collection of the urine and blood and all in the extra peritoneal tissues around. But if the injury is in the bulbar part of urethra, there will be collection of the fluid around the penis scrotum. It can go above till the level of anterior abdominal wall. So you can see this part is the membranous urethra. Membranous urethra is surrounded by urogenital diaphragm. The location of membranous urethra, it is traversing through UGD. What is UGD? Urogenital diaphragm. And UGD, which is a urogenital diaphragm, it is containing sphincter urethrae and it is containing deep transverse perineal muscle. What does it contains, my dear students? It contains deep transverse perineal muscle. Deep transverse perineal muscle. Kona, ma'am, here perineum is injured is mentioned na. Perineum is, but collection of fluid is important. Perineum is the whole area, no. Perineum is the, actually we have got perineum at the junction of superficial and deep perineal pouch. Kona, we have got perineum at the junction of, perineum is at the junction of superficial and deep perineal pouch. Perineum is injured, but collection of fluid is around the scrotum. So the most common injury will be the bulbar urethra. So most common, if there is a pelvic fracture and all, then only we will go with the membranous urethra injury. Is it okay? Is it okay, everyone? Gautam, is it okay, everyone? So we will go with better answer, bulbar urethra. See here, rupture of the bulbar urethra happens and the fluid collection, urine is in the scrotum. So urine in the scrotum and around the penis. See this image, everyone, those who are confused, urine collection is around the scrotum. Urine collection is around the scrotum, is in the penis, and collection is in the superficial perineal pouch and then going upward till the level of anterior abdomen. If membranous part of urethra, urogenital diaphragm or pelvic fracture, heavy injury occurs, then only membranous urethra occurs and there is extravasation of urine around the extraperitoneal tissue. Is it okay? Now the next question, episiotomy incision was extended posteriorly beyond perineal body. The structure immediately posterior to it, which structure is injured? Episiotomy incision was extended posteriorly beyond the perineal body. I will just stand for a few seconds. Don't worry, dear students. I am just standing because I am not taking a break, and to sit long duration on one position is not good. Okay, is it okay? Like this. Just I will stand for a few seconds. Episiotomy incision was extended posteriorly beyond perineal body injured. The structure immediately posterior to it. What structure has been injured in this case? What structure has been injured in this case? What structure has been injured in this case? Whether it is external anal sphincter, whether it is the ischiocavernosus muscle, whether it is the bulbospongiosus muscle, whether it is the urethral sphincter. So again, I am getting a multiple answer, and my dear Pihu, my dear Mirja, you are absolutely right. Yes, the right answer is external anal sphincter. Actually, this is the question also asked in the gynae and ops. We know that perineal body is a junction, is a structure where the 10 muscles are interlacing. Okay, we have got two bulbospongiosus muscle interlacing at this location. We have got two levator ani muscle of both the side. We have got two superficial and deep transverse perineal muscle, making a total of 8 muscle. One external anal sphincter and the one is longitudinal muscle coat of rectum and anal canal. So how many muscles are interlacing at this level? 10 muscle, of which 4 are paired and 2 are unpaired. Okay, so now see this. Here we can see this is the location of perineal body, no doubt about that. See here, this is the location of perineal body. This is the location of perineal body, my dear students. And here you can see 10 muscles interlacing, the bulbospongiosus muscle. the superficial and also the deep transverse muscle, making a total of 4 plus 2, and levator ani muscle is 2, and external anal sphincter is 1, and also longitudinal muscle coat of rectum and anal canal. So exactly if the incision is going more posteriorly, the external anal sphincter will be injured. So the right answer is external anal sphincter. And many of the students has given the right answer, so a clapping goes for them. A clapping goes for them. Absolutely correct, dear. Done it. Now, this is the most easy question. Fertilization occurs in which part of the fallopian tube? Fertilization occurs in which part of the fallopian tube? Fertilization occurs in which part of the fallopian tube? Fertilization is occurring in which part of the fallopian tube? Most easy question. Everybody will give the right answer, I think. Everybody. Okay, I will sit again if you want. The right answer is ampulla. Absolutely correct. No need of explanation. Okay, now I will come to the other question. Actually, these are again the questions from INICET. So let's have, yeah. Is it okay? Yeah. So just identify the structure that does not form the laryngeal cartilage. So you have to know what is A, what is B, what is C and D. Now tell me the right answer. Which are, we know that how many laryngeal cartilages are there? There is 3 unpaired laryngeal cartilages and there are 3 paired laryngeal cartilages. So we know that there are 3 paired and there are 3 unpaired laryngeal cartilages. Now you have to identify among this A, B, C, D, that which is the unpaired laryngeal cartilage. Which is the unpaired laryngeal cartilages. Keep going, dear students, keep going, keep going. So yes, I am getting, hyoid is the right answer. Yes, now tell me which is the hyoid? Which is the hyoid? Whether it is the D, whether it is the A, whether it is C or whether it is B. I will show you the image for it. Yes, Pihu, you are absolutely right. That total 9 cartilages are there, and which is the hyoid one? We have to just go with this. So exactly, if you will see, this is C is the epiglottis and A is the hyoid bone. Those who have given A are definitely right answer. So here you will see this image. So definitely if you will see this, A is the hyoid bone. Now if I talk about the B, this is the cut part of, if we see the B, this is the cut part of thyroid cartilage. And C is the leaf-like structure epiglottis. C is epiglottis. C is epiglottis. And we have got D as the arytenoid cartilage. D as the arytenoid cartilage. So basically, all these we know that if I talk about epiglottis, arytenoid, corniculate, cuneiform. So 3 unpaired cartilages of the larynx are hyoid. 3 unpaired laryngeal cartilages are thyroid, cricoid, epiglottis. 3 paired one is arytenoid, corniculate and cuneiform. 9. So hyoid bone is the bone which is not the part of laryngeal skeleton. So yes. Now easy one. Which structure lies behind the marked area in the lateral aspect of the skull? So what you are seeing is the lateral aspect of the skull, and you have to tell me. So you have to tell me which structure is present behind the marked area. So firstly, identify this area. This area, I will give you a hint. This is an H-shaped suture, my dear students. This is an H-shaped suture. So what is this area? You can identify. A very common question and very important question for INICET. Repeated number of times, but only the things which is asked is twisted. Not the same question being repeated. Same topic. If you will see INICET exam, so many times the same topic get repeated. But whichever topic MCQ has been asked, go the neighboring part also. Study the neighboring aspects also, because exactly not the same question, but related topic will be asked. So structure behind the marked area, it is a sella turcica, lesser wing of sphenoid, posterior clinoid process or carotid canal. Yes, everyone is right. That is Doc is right. Here Canoj is right, Pihu is right, everyone is right that it is pteron. But what about the answer? What about the answer? whether it is the posterior clinoid process, whether it is the lesser sphenoid, whether it is the cilla, turcic and carotid canal. My dear students, let me explain it. Actually, pterion is the level where the four bones are meeting. So exactly, if you will see here, we will have the four bones are meeting at this location. Okay, no doubt about that. This is S for sphenoid. We will have S for sphenoid, T for temporal, F for frontal and P for parietal. So is it okay? Four bones are meeting and this is the H-shaped suture, that is pterion. This is pterion. And deeper aspect of the pterion, we have got one artery. What is the name of that artery? Middle meningeal artery, frontal trunk. Anterior branch or middle meningeal artery, frontal trunk. So basically the marked area in the structure is a pterion, which is H-shaped structure, and it is susceptible to injury. And we know that in case of the cranium dura, is the cranium dura containing, can anyone give me the answer? Is the cranium dura containing epidural space? No. Spinal dura matter. If we talk about meninges, meninges has got three layers. As we proceed from outside to inside, we have got the dura matter, we have got the arachnoid matter, and we have got the pia matter. Now, when I am talking about the epidural space, in normal cases, it is only present in the spinal dura matter, okay, or spinal meninges. But in pathological condition, when there is an injury on the lateral aspect of the skull, so when there is a direct hit on the lateral aspect of the skull, the H-shaped suture, that is pterion, is injured, and we will have bleeding from the frontal branch or anterior trunk, frontal trunk of the middle meningeal artery, which is a branch of maxillary artery, and this will lead to the condition of epidural or extradural hematoma. And we know that it is a point where the lateral four bones are meeting, and exactly if I have to choose one, I will go with lesser wing of sphenoid is located at this location. So we will have 2 as the right answer, lesser wing of sphenoid. So I got Rasta Mirja, I got Shriyan Gond, I got Thalapati, I got KP as giving the right answer is the lesser wing of sphenoid. Absolutely correct, dear. Absolutely correct. Okay, other are wrong because these are not located at this location. So we will go with the right answer. Now, all of the following nerves are associated with ocular movement except. So, A, B, C, D. So, what I will do for you, I will first enlarge the image. This is a image in the cranial cavity, as you can see. So, firstly identify the nerves. Then you have to give me the answer whether it is A, B, C, D. So, please have a look. Take your time, identify A, B, C, D. And then we will have that which is not involved in ocular movement. Which nerve or structure will not be involved in ocular movement? So, I have enlarged this image. Enough time for identification or a guess, and give me the answer A, B, C, D. So, actually, yes. So, let me ask the others. Actually, one hint is there which will give you the answer. I know that extraocular muscles are supplied by which nerve? Extraocular muscles are supplied by oculomotor, the trochlear and the abducer nerve. We know that. We have got the third cranial nerve which is supplying all the extraocular muscle except the lateral rectus, which is supplied by the abducer nerve, except the superior oblique, which is supplied by the trochlear nerve. So, we are all aware of this. That means the odd man out will be those which is lying close to it. Actually, A is the right answer, and I think Kona Pihu has given the right answer, and absolutely correct. Yes, the right answer is given by them, and absolutely correct. Let me just show you this image. So here you can clearly see this is the ophthalmic artery, and close to this nerve in the optic canal is the optic nerve. So definitely optic nerve is not giving innervation to any of the extraocular muscles, and definitely A is the right answer. A is the right answer. Rest all muscles are related. So if I talk about this structure, so we will have, if we talk about this structure, so we will have B as the third, so we will have B as the third cranial nerve, we will have C as the fourth cranial nerve, and we will have D as the sixth cranial nerve. Actually, the identification, if it is not clear also, you can clearly identify the optic nerve because it is traversing, it is lying close to the ophthalmic artery in the optic canal, traversing close to it. So, definitely the A is the right answer. Okay, so we will have optic, oculomotor, trochlear and abducent. Okay, dear. So we actually, yes, if you want to know, yes, Pihu, trigeminal nerve has got 3 divisions. Okay, we have got 3 divisions from trigeminal nerve: ophthalmic, maxillary and mandibular. So mandibular is going through foramen ovale, maxillary through foramen rotundum, and ophthalmic is through superior orbital fissure. Superior orbital fissure. Actually, other nerves are not clearly located, but here trigeminal branch will go. This nerve will be from the trigeminal. Is it okay? Pihu. So superior orbital fissure, which is lying below the superior lesser wing of sphenoid, there will be the branch from the ophthalmic division of the trigeminal nerve. Okay. Okay, Pihu. So exactly, you can see here, basically you have to identify the location and know about the nerve. So I will show you another image. So Pihu, this is for you. You can see here, just below the lesser wing, you can see the ophthalmic, maxillary and mandibular is traversing. Okay, so that is important. Actually, I can understand the image will not be so clear that you will see all the division, the 3 branches traversing field, but you can know the location. You are knowing that the location of the ophthalmic branches of trigeminal nerve is just below lesser. So this will be superior orbital. Let me write with, यहाँ पे superior orbital fissure होगा. This will be maxillary, foramen rotundum and this will be foramen ovale. So this is how the 3 division of the trigeminal nerve will traverse. Okay, here will be the facial and vestibulocochlear nerve. That means internal acoustic meatus, my dear. This is glossopharyngeal and vagus will be, if I talk about glossopharyngeal and vagus both, this two will be from the jugular foramen, along with the accessory nerves also, along with the 11th nerve and hypoglossal canal. Hypoglossal canal. Yes, Pihu, thank you so much. Yes, thank you, dear. Extraocular muscles action also you have to know. So how you are going to remember the extraocular muscles action? It becomes very easy for remembrance. I will tell you how you are going to remember. Actually, the recti muscle, medial and lateral rectus will have just one action. 3 planes में action होता है. If I am talking about medial and lateral rectus, they are just causing adduction and abduction of eyeball. If I talk about obliques, their action is just opposite to their name. If it is superior oblique, it will cause depression, intorsion and abduction. And if it is inferior oblique, it will cause elevation, extorsion and abduction. The intorsion and extorsion movement will be taking place around AP axis. Okay. If I am talking about superior and inferior rectus, they will have the action according to their name. Superior rectus will cause elevation and inferior rectus will cause depression, along with superior rectus intorsion and inferior rectus extorsion. My pace is okay. Actually, this is a quick revision class for the INICET high-yield topics and high-yield MCQs. So only I am slightly going quickly. Is it okay, everyone? Please don't mind. Is it okay? Because I want to cover up as many as MCQs we can do before the examination. Because I think all of you have got a detailed discussion already with Dr. Aswani sir. So I think this is just a quick recapitulation of the things, and many things must be known to you. If I have gone through a topic, I have gone through much more detail. But now I am, we will keep this crisp, brief explanation of MCQ so that the topics is also explained very briefly. Okay, dear. So let's move on to the next. Okay. Speed is fine. Please continue. Okay. Patient having paradoxical respiration, which of the following nerves is most likely to be affected? Patient having paradoxical respiration, which of the following nerves will be most likely to be affected, whether it is A, B, C, D? Patient having paradoxical respiration, which of the following structure is so that means I will just A, B, C, D, no, I will just show you this image. This is a cadaveric image. Just identify what is A, what is B and what is C and D. Yes, you are right. That has to be phrenic nerve. Yes, you are absolutely right. That has to be phrenic nerve. Now, how you are going to identify it is a phrenic nerve? So, that is the twist here. How to identify the phrenic nerve? But one thing we know about the relation of the phrenic nerve, and that is how you are going to solve. Actually, definitely the right answer is C. C is the phrenic nerve, dear. here, because it is traversing the anterior aspect. Okay, see here. This is exactly the nerve, and we know that paraoxical. So basically phrenic nerve we have to see. Okay, just a minute, sorry, C, D, I have already confused this. So basically I will just come to this anterior aspect. Let us see the tracheoesophageal groove. Okay, my dear, we will have the tracheoesophageal grooved. Now here what happened, yes, we will come to this anterior aspect to the, so you just tell me pleura or pericardium, anterior aspect, which nerve goes. Okay, let me just go through this image. So we will have the anterior aspect as the phrenic nerve, but here we can see the tracheoesophageal groove is there. So this nerve will be recurrent laryngeal nerve. Okay, sorry, this nerve is recurrent laryngeal nerve. Okay, so that is the hint. And then closely we will see this image. Then you can see this is the vagus nerve which is going. So this more laterally we will have the vagus nerve. So we will have right and the left vagus nerve. So please don't answer is phrenic nerve. We will have right and the left vagus nerve also, and other than that we will have this nerve which will go more lower down, and laterally we will have the phrenic nerve. Okay dear. So basically most anteriorly if we would talk about, so actually how to most anteriorly if it is going. So if you will see the nerve D, it is going more anteriorly in place of scalenus groove, and basically if you see this, it is more medially and related medial aspect of thyroid gland. So it is lying in the tracheoesophageal groove, recurrent laryngeal nerve. This will have the carotid arteries, internal jugular vein. So here will be the A as the vagus nerve of both the sides. So definitely D should be the right answer. That is the phrenic nerve. Phrenic nerve. Okay. PDF we will see dear. Okay. So we know that right and the phrenic nerve has got different cores, and keeping in the mediastinal pleura, both is going anteriorly. So most anteriorly if we will see the structure here, that is the phrenic nerve. I think slightly the cadaveric image which I should have used in this image should be slightly lower down. But also you can have the rule out policy. Rule out policy that C तो answer नहीं होगा, recurrent laryngeal nerve है, और ये जो structure है ये vagus nerve है, because it is exactly lying in the carotid sheath between the internal jugular and carotid arteries. So we are left with the D as the answer. So definitely D is the right answer. Okay dear. So here D is the right phrenic nerve. D is the right phrenic nerve. But I should have given more clear image, I think. Okay. Now this is another question. Please mark the right answer dear. In lymphoid organ listed below, reticular fibers are found in which of the following organs? This is easy one. This is an easy one. Okay. 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 Got it? So actually, yes. So here, just I wanted water. So, okay. In lymphoid organ, okay, in lymphoid organ listed below, reticular fibers are not found in which organ? Whether it is the thymus, whether it is the spleen, whether it is the lymph node, or whether it is the bone marrow. So let me see who is giving. I absolutely correct. Yes, absolutely correct. The thymus gland is the right answer. One thymus gland is the right answer. So in place, absolutely correct. Again, a thumbs up goes for you. So in place of reticular fibers, what are the structure located in the thymus which is giving support to the thymus gland? The structure is epithelio-reticular cells. Epithelio-reticular cells. So actually, epithelio-reticular cells are present. Actually, when I talk about all the lymphoid organs, all the lymphoid structure, they have got reticular fibers as a supporting network. But if I am talking about thymus gland, it is having epithelioreticular cells as the supporting structures in the connective tissue framework. So we will have epithelioreticular cells as the right answer. Now, as the right answer, and it is also forming the part of blood thymic barrier. So epithelioreticular cells as very important role, which is the blood thymic barrier. So it is actually, we know thymus gland is having only T cells, which is important for cell mediated immunity. We know that it is having only T cells, which is important for cell mediated immunity, and the immature T cells, if I am talking about immature T cells, has to be protected from the antigens of the blood, not to be attacked, so that an antigen antibody reaction doesn't occur. So for that prevention, there is epithelioreticular cells along with the capillaries and along with the basement of capillaries forms BTB, that is the blood thymic barrier. Okay, dear. Now next, histopathological specimen from the autopsy of 24-year-old patient is shown. Can you tell me the structure is not found in? The structure is not found in. So please mark the right answer, dear. So you have to, yes, Dr. K, epididymis. Okay, okay. So, okay. Actually, the one thing is that sometimes what happens, it becomes very difficult for us. One thing is clear from this. If you will see this slide, you can see it is having cilia. Why? Because you can see a part of cartilage is there and cilia. So this structure is cilia, and we know that cilia is motile and it is present in the structures where we want motility. So it is an actually, if I talk about cilia, so exactly if I talk about the cilia is important for the motility. So basically it is an apical extension which is having mobility also. So it is actually found in fallopian tube, it is found in the respiratory tract, basically it is found in trachea and the bronchus, and it is found in ependyma. What is ependyma, my dear students? Ependyma is the lining epithelium, ciliated columnar epithelium found in the lining of central canal and the ventricles of the brain. And if I talk about epididymis, it is the right answer. Why? Because it is having no cilia, it is having stereocilia. So stereocilia are longer microvilli, but it is not mobile. It is immobile. Immobile. So stereocilia is immobile. So if I have to go with one answer, I will go with B, epididymis. Is it okay? Yes, absolutely right. Sonam Alam, absolutely right. Now, epididymis is the right answer because it doesn't contain cilia, is importantly located in the several structures like trachea and the other areas, but it is not present in the epididymis have got stereocilia. Okay, done with this. Middle radioulnar joint is which type of joint? Middle radioulnar joint is which type of joint? Whether it is a plain type of synovial joint, whether it is a primary joint, whether it is a secondary or a fibrous joint. Plain radioulnar joint is which type of joint? Plain radioulnar joint. No, sorry, middle radioulnar joint. Sorry for it. Actually, we are talking about radioulnar articulation, which happens to take place at 3 locations. There is superior radioulnar articulation, there is inferior radioulnar articulation, and there is middle radioulnar articulation. So we have to name it whether superior is which type, whether inferior is which type, and whether middle is which type. So I thumbs up goes for Pihu and Sonu, and both of them has given Rasta Mirza. Absolutely correct answer. Yes, dear, you are absolutely right. The correct answer is fibrous joint. It is a type of syndesmosis. So basically, middle radioulnar joint is a type of syndesmosis, which is again a type of fibrous joint. Yes, absolutely right. So actually, if you will see the articulation, we have got proximal and we have got distal radioulnar articulation, which is a variety of pivot type of synovial joint, which is also called as trochoid joint, and the middle one is a type of syndesmosis, which is a type of fibrous joint. So the right answer is syndesmosis, which is a type of fibrous joint. Yes, dear, absolutely correct, dear, absolutely correct, absolutely correct answer. Now let's come to the next one. Action of the muscle at the hip attached to the marked area here. So if I am talking about the correct answer here, the first thing is that you have to identify. So what you are seeing is the femur. So in femur, you have to identify that line which is a arrow marked, and you have to know what is it, and then you have to tell me about the muscle attached on it, and then you have to know about the action of that muscle. So actually, this is containing 3 questions. Action of the muscle at the hip attached marked structure. So yes, you are absolutely right. So I got an Kona is telling it is gluteus maximus. So what is that bony structure? What is that bony? Gluteus maximus is inserting at 2 locations. One is iliotibial band and the other is gluteal tuberosity. So my dear students, this is gluteal tuberosity. So my dear students, this is gluteal tuberosity, and in gluteal tuberosis, if I talk about the major part of gluteus maximus muscle, which is arising from the dorsal aspect in the region of the ilium part, and inserts in the major part inserts into iliotibial tract or iliotibial band, and another part inserting into gluteal tuberosity. If this is gluteal tuberosity, the muscle is gluteus maximus, and we know that gluteus maximus has got an important action of extension of the hip along with the hamstring group of muscle. So it is causing, if we talk about the back muscles, they are extensors of the hip and they are flexors of the knee. Anterior muscles are extensions of the knee and flexors of the hip. So gluteus maximus is extensor, and basically along with extension it also causes slight lateral rotation. So we'll go with B as the right answer. We'll go with B as the right answer. Now see here, extension and lateral rotation is the right answer. The muscle is gluteus maximus attached on gluteal tuberosity. If you want to have a quick recapitulation of the attachments, what you can say, origin is from the gluteal surface of ilium and also from sacrum coccyx, insertion into iliotibial band, gluteal tuberosity, innervation is inferior gluteal nerve, and action is hip extension and slight rotation, lateral rotation. Now, identify the level of cross section shown in the image given below. So, identify the level. So, actually this is like so close they have marked. So basically in this one more diagram I have kept, I will come to that. So basically like this one more image is there. Pihu, yeah, what happened? You all are Pihu, I am. So how can Pihu has given a right answer? Very good dear. Yes, T3 and T4. Actually T4 is correct. So we will go with most correct T3 and T4. Actually T4, why I will tell you, because there is one of the structure which is giving us that hint. So basically we will have this lung. So basically this is P for the posterior and this is A for the anterior. No doubt about that. This is P and this is A. And we will have this luminate. So this is PY because these are the vertebrae and these are the lungs of both the sides. Now other than that, we will have the parts exactly. We will have this collapsed type of structure is there. The lumen is not slightly collapsed type of lumen. So this is superior vena cava, this may be. And here also we will have this structure is the, yes, basically there is bifurcation of the trachea, which is a cartilage part is there, and the cartilage part is slightly bifurcating here. So this T trachea cartilage bifurcation is there, and this is the esophagus which you are seeing. So basically that is giving us the hint that T3 and T4 is the right answer. So here you can see we are seeing the esophagus, no doubt. We are seeing the brachiocephalic vein also, and the part of bifurcation of trachea and carina is seen. So this is A for the anterior aspect and this is P for the posterior aspect, and this is the brachiocephalic vein and the superior vena cava. So definitely the cartilage part is also seen here, which is definitely this is esophagus, and here the two parts division. So here what happens, the most important point is this is the two-part division of the trachea, that is tracheal bifurcation. So we will go with T3, T4 as the right answer. Actually what I have done, I will not go actually landmarks. I have segregated this notes as a landmark of how to identify the cross sectional areas. So important things which is occurring at this word, like C3 level hyoid bone, C4 level thyroid cartilage bifurcation of common carotid artery, C6 cricoid cartilages, T1 sternoclavicular joint, T3 T4 aortic arch, T4 T5 also the bifurcation of the or trachea, T6 upper border of liver, T7 inferior angle of scapula, T8 T9 xiphisternal joint, T7 T10 is esophageal hiatus, L1 is the transpyloric plane where number of structures, hilums of the kidneys, then we have got the pylorus part of the stomach, the ninth costal cartilages, conus medullaris, lower end of the spinal cord ending, L3 level umbilicus, and also L3 level we will have the arteries, we will have inferior mesenteric artery, we will have superior mesenteric artery, L4 the iliac crest and bifurcation of aorta, L5 inferior vena cava formation, and S2 is the dural sac termination. So actually what I have done, this is the main levels which you have to know. This is all the table has been made from number of books, and you have to know this levels which will be highly beneficial for you, the landmarks. Okay. Structure on the top is the arch of aorta, which is also seen. So basically here the other point is the structure of the arch of aorta is also seen. So we will mark T3 and T4 as the right answer. Now level of visceras goes up to which of the level on deep inspiration? See here, this is A, B, C and D. This is A, B, C and D, and this is the level of visceral pleura going on which location on deep inspiration? Pleura. Okay, they are asking about visceral pleura. Okay, pleura. So we know that lungs and the pleura relation are pleura is 2 ribs below and lung is 2 ribs above. If we talk about the relation in mid clavicular, mid axillary and scapular line. So that is in case of lung it is 6, 8 and 10. In case of pleura it is 8, 10 and 12. So deep inspiration. The pleura will go till the level of anyone. Please mark the right answer. Don't worry, it will take another half an hour only. I think everyone is exhausted. So quickly, I will solve the MCQs quickly. Few of the MCQs are repeated one now. Quickly we will solve. Don't worry, half an hour more, just half an hour more. Exhausted students, exhausted. Students are getting exhausted or what? Yes, B is the right answer. Yes, B is the right answer. Actually, when we are talking about B level, lower border, we know that lungs will have 6, 8 and 10 relation, and pleura relation on the will be 8, 10 and 12. So basically in deep inspiration it will be go to the level of the 11th rib and all. So we will mark as the B level, which will be the level till which it can descend. Okay. I will just go to the next. Muscle attached on the marked arrow. You have to just remember this. And we know that in deep breathing, 6 to 10 centimeters, however it moves, extending till the level of 6th or 11th rib on the right side. So we will mark this as the B level. Most correct. Now muscle attached to the marked area. So let's take another few minutes to solve few MCQs more. So muscle attached on the marked area, the arrow marked structure, please you have to see this arrow marked area and you have to tell the muscle attached. Maybe in the GTs and GTs you must have solved this MCQ. What would be the right answer dear? So actually you have to clearly know about these muscles of the thenar region and all. So yes, Pihu is telling, so Pihu has studied very well. Good one Pihu. Every answers you are telling right. Yeah, it's the opponent's pollicis. Let me show you. Actually, opponent's pollicis is inserting at the thumb radial side. The best thing is that how we are going to identify this is the thumb and this is the thumb, and you can see the muscle inserting onto the thumb. As you can see the proximal aspect and close to it, As you can see, the metacarpals and also definitely opponens pollicis. So you have to just know that origin is from transverse flexor retinaculum, but insertion is on the thumb radial side metacarpal bone. So definitely that is the right answer, opponens pollicis. Okay. Abductor is pollicis is not, because it inserts onto the side of the base, and palmar flexor pollicis longus also inserts on the proximal aspect. So basically most correct answer will choose the opponens pollicis. Just remember it inserts onto the thumb close to it. Okay. Fornix contain which type of fiber? Very important question asked in the previous year. Fornix contains which type of fiber, whether it is association, commensural or projection fibers? Any answers coming up? Exhausted? Please mark the right answer. Fornix. Basically, we know that if we have to talk about the projection fibers, which is connecting the cortex with the subcortical area, we'll mark projection fibers as the most correct answer. That is the fornix. But other than that, fornix is also containing association fibers and commensural fibers. So basically, four. Yes, yes, Mirja, yes, Kona, absolutely right. It is containing all three types of fibers. Basically, very right. So actually, most of the fibers are of projection types, but fornix is also connecting the part of it is also connecting corpus callosum, cingulate, gyrus, and it is also having three types of fibers, all the three. So it is constituting as the three types of fibers. Now, ito cells are present in which of the following areas of the liver? Ito cells. Ito cells are present in space of Dies or space of periportal location is called as space of Moll. What is the other name of periportal space? It is called as space of Moll. Now, give me the right answer. Ito cells are present in which part of the liver? Ito cells are present in which part of the liver? Kona, absolutely right, is the space of Dies. So if I talk about the space of Dies, which is called as perisinusoidal space, perisinusoidal spaces, it contains ito cells, it contains the it also contains the ito cells, and it also contains the macrophages and microvilli of the Cooper cells. And perisinusoidal space of it is called perisinusoidal space, and it contains these all. Periportal space is called a space of Moll. Which of the following is not a content of carotid sheath? Which of the following is not a content of carotid sheath? Which of the following is not a content of carotid sheath? Internal carotid, so no doubt about these. No doubt about this, because we know that carotid arteries, common carotid arteries, ICA, IJV and that of vagus nerve. All these are the contents of carotid sheath. We know definitely, means this is commonly, but you have to choose which is exactly not. So two हो सकता है, या तो ग्लोसोफेरेंजियल आंसर होगा या सिंपैथेटिक चेन होगा, कौन सा आपको चूज करना है? Sympathetic chain is embedded in the posterior aspect of the carotid sheath. So Vishwanathan is telling, but if I have to choose one, I will not go with ninth dear, which is so exactly sympathetic chain. Why I will tell you, because we know that these three structures are glossopharyngeal is also, if I talk about glossopharyngeal also, so basically glossopharyngeal descends from the jugular foramen within the carotid sheath on the lateral aspect. So basically this is more posterior, this is posterior, but at times ninth cranial nerve can also descend in the carotid sheath. So if I have to choose one, I will go with 4. So those who have given the sympathetic chain as the right answer, for them goes a thumbs up. Goes a thumbs up. Glossopharyngeal nerve descend anteriorly lateral aspect in the carotid sheath. See this. Sympathetic chain is not inside the carotid sheath, it is posterior to the carotid sheath. So we will mark sympathetic chain as the right answer. Superior cerebral peduncle is lying at which location? So superior cerebral peduncles will be seen in medulla, transverse section, pons or midbrain. Easy one. This is a easy one. This is a easy one. Superior cerebral peduncle is located at which level? superior cerebellar peduncle. So we have got three peduncles, superior cerebral peduncles, we have got middle cerebral peduncles, we have got inferior cerebral peduncles. Inferior cerebral peduncle is connecting the medulla with the cerebellum, connecting fibers are there, afferents, efferents. Middle cerebral peduncle is connecting pons with that of the cerebellum, and we talk about the midbrain, it is connected by the superior cerebral peduncle. So definitely 3 is the right answer. Definitely 3 is the right answer. Medial lemniscus is formed by which of the following structures? Medial lemniscus. Medial lemniscus is formed by which of the following tract? I think few of them has got slow. The network is slow, so they are answering the previous questions which I have asked. So that pace is not going. Okay, some of the students are answering the previous question. Medial lemniscus is formed by which of the following? Please mark the right answer. So P, yes, absolutely correct. It is the fasciculus gracilis and fasciculus cuneatus. Fibers of fasciculus cuneatus and fasciculus gracilis, the posterior column tract is basically having the second order neurons from the nucleus gracilis and nucleus cuneatus, and they will pass through the medulla as forming internal arcuate fibers, will decussate and will lead to the formation of medial lemniscus. Will lead to the formation of medial lemniscus and will form the part of dorsal column pathway. Yes, definitely. Cells lining the isthmus of gastric pits. Cells lining the isthmus of the gastric pit. Cells lining the isthmus of the gastric pit. Cells lining the isthmus of the gastric pit. So Monica Sharma has given the right answer. It's the stem cells. Yes, it's the stem cell. So basically stem cell is the right answer. So if I talk about the stem cells, it is actually having mitotic division and it can give rise to the other forms of the cells, and they are situated in the isthmus of the gland. So if I talk about the fundic gland, it is situated in the isthmus part of the gland. See here, this is the stem cells. Neck cells, so exactly mucous gland will be on the neck, and if I talk about the stem cells which will be in the isthmus part, so this is the isthmus part which will have the stem cells. Now why chief cell is not the right answer? Because they will actually formed in the mid portion. Parietal cells is also not the right answer. They will be also not, they will be also go downward in the base, and mucous neck cells in the neck region. So we will have the stem cells in the stomach part. Identify the pariform fossa. Which is the pariform fossa in this diagram showing the vocal internal, showing the laryngeal cavity? Identify the pariform fossa in the given image. B is absolutely right answer. Yes, we can see this area is the piriform fossa, which is called as the lateral food channel. So what is piriform sinus? It is the lateral food channel, and this is actually lying on the either side of the laryngeal cavity, and it is also called as smuggler fossa. Internal laryngeal nerve can be injured if there is some fish bone or any foreign body stuck on it. Here if I talk about the A part, it's the A part is the epiglottis, E for epiglottis. We have got also the B as the piriform fossa. We will also have the ventricular false fold and airy epiglottical fold. Okay. So boundaries of the piriform fossa, it's a potential space lying on the lateral aspect of the lamina of thyroid. It is bounded by the mucous membrane of the lamina of thyroid cartilage, and medially there is lying airy epiglottical fold. It is lateral food channel. Then pretracheal fascia of deep cervical fascia encloses all structure except which of the following structure is not enclosed by the second layer of the deep cervical fascia, that is pretracheal layer. Pretracheal layer of deep cervical fascia closes all except. Actually, the correct answer will be sternocleidomastoid because it is enclosed by investing layer of deep cervical fascia. Yes, absolutely right, Rahul, Abbas. And these three layers are closed by the pretracheal layer of deep cervical fascia. Absolutely correct here. So actually, three layers are there. More superficially, if we talk about investing layer of deep cervical fascia, it is enclosing the sternocleido. So this is SCM and this is the trapezius muscle. These two muscles are enclosed by investing layer of deep cervical fascia. So this is the right answer. Middle layer encloses the trachea, esophagus and all, and infrahyoid muscles few. Transitional epithelium is present in all except. Transitional epithelium is also called as urothelium, and give me the right answer. So transitional epithelium is present in all except ureter, renal pelvis, minor calyces or membranous urethra. Transitional epithelium is present in all except. Absolutely correct. Membranous urethra. All these structures is having urothelium. So membranous urethra is the right answer because it is having stratified or pseudo-stratified columnar epithelium. Yes, absolutely right. Now, neurotransmitter emitted by the green structure. Neurotransmitter emitted by the green structure. Whether it is glutamate, whether it is dopamine, whether it is. So, first thing is that identify the structure. This is a coronal section of brain, and in coronal section of brain, there will be slightly bluish, means some structure which will be having a pigment, and they are located in the coronal section at this location, which is also a part of basal ganglia, and this is the hint given to you. And what is this? Yes, dopamine. This is substantia nigra. This is substantia nigra. So basically, dopamine marked structure is substantia nigra. Neurotransmitter emitted is dopamine. So you can clearly see, if you see the coronal section, you can see this dark staining structure is the dopamine, is the substantia nigra. So all the neurotransmitted and emitted by which structure has been listed here, but I am not going into much detail because I have got less time now. Describe the difference between exocrine, pancreas and parotid. What I have done, I have taken so many questions. Describe the difference between exocrine, pancreas and parotid gland. Which will be the best answer here? Absence of striated duct, presence of acidophilic serous, apical, yeah. Rahil Abbas, again a thumbs up goes for you. What a great answer. Yes, actually striated duct is absent. Striated duct is absent. Striated ducts are not present here. Striated ducts are not present in the pancreas. Striated ducts are present in parotid. Okay. In case of exocrine, pancreas will have centroacinar ducts. Yes, dear. All other structures are present in pancreas. Yes. So see here, when you see the slide of uh, parotid gland, you can see there are so many ducts. So many ducts will be there. Serous SNS will be there. Duct will be there. Few mucous SNIs can also be there. But when you see the slide of pancreas, there is no, there is less ducts. There is less number of duct, and in place there is centroacinar sinus, which is the duct which is arising from the inside sinus of the SNI of the pancreas, and less number of duct is there. Now, injury to which part of the internal capsule causes contralateral hemiplegia? Injury to which part causes contralateral hemiplegia? Injury to which part of internal capsule causes contralateral hemiplegia? Retrolenti, sublenti, anterior or posterior limb? So dear students, I am going slightly at a faster rate because I want to complete in another 20 minutes. Okay. Okay dear, I will just sit for some time. Okay. Yes, dear Shiv Kumar and Aradhana Arora, absolutely right. Yes, is the posterior limb, dear, absolutely correct. Yes, posterior limb is actually having the corticospinal fibers, and corticospinal fibers, if injured, will cause contralateral hemiplegia. Okay, this is known to you. This is already done. I will not go. This is the fourth. This is the trochlear nerve. This is the superior oblique muscle. This is already done. This is a repeated question. Repeated question already done, dear. Already we have solved it. At which level? Superior cerebral decussions in midbrain. We have already done this also. All other contents of carotid sheath, this exactly will have already done. These are, this already we have done. This we have already done. So leave it. We have already done. Yeah, we have already done. Why to rub? We have already done. This also 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 done. This is also done. So these questions are already done. Is it okay? We have already done. This is also done. Few questions more. Which of the following are the branches of anterior division of internal iliac artery? If we go in details of 6 years of whole question, I think we will require 8 hours minimum, 8-9 hours. Okay. Which of the following is the branch of anterior division? Actually, I will give you a mnemonic SIL. SIL is a branch from posterior division. So if I talk about SIL, SIL is a branch from posterior division. It's a branch from posterior division, iliolumbar, lateral sacral and superior gluteal artery. All other important arteries are the branch from anterior division. Okay. So basically, if we talk about the branches, all of the following are branch from anterior division except. So basically, which are the branches from posterior division which we have to search? So what I told you already, the answer will be like this. So we know that okay, we know here superior gluteal is a branch from posterior division and inferior gluteal is from anterior, superior vesical anterior. This is also anterior. These are, so actually all these are anterior. So 2 is the right answer. Absolutely correct, Pihu. Absolutely correct, dear. Yes, what a great answer. Yes, 2 is the right answer. So we know that this is an image where showing the branches from. So we have got superior gluteal, lateral sacral and iliolumbar. These are from the posterior division. Rest are the branches from anterior division, obturator, superior, inferior vesical, vaginal, uterine, middle rectal, internal, pudendal and inferior. All these are branches from inferior gluteal. All these are branches from anterior division. That means go through the branches of internal iliac artery. Okay. In subclavian artery block at the outer border of first rib, which of the following arteries helps in maintaining the circulation of upper limb? Means basically this is a question of scapular anastomosis. This is a question of scapular anastomosis, and we know the scapular anastomosis is between the branches of first part of subclavian artery and third part of axillary artery. So basically, other than that superior thoracic artery, which is a branch from the first part of subclavian artery, all these take part in anastomosis. So the right answer is B. That is 1, 3 and 4. 1, 3 and 4. 1, 3 and 4. So basically, we know that The anastomosis around the scapula is happening between the branches of subclavian artery first part, that is thyrocervical trunk, and that of suprascapular artery, and branches from the third part of axillary artery, that is from the branches of circumflex scapula, which is the branch from the subscapular artery. So basically the correct answer is 1, 3 and 4. 1, 3 and 4. Yes, correct. Now, most specific complication which is related to the central line inserted below the bone: empyema, thrombophlebitis, chylothorax, or arterial injury. Arterial injury. Okay. Yes, arterial injury is the right answer, dear. Yes, most common is arterial. A male patient has already taken first dose of COVID vaccine, and the health worker then notices that his shoulder was flat, flabby, shoulder asymmetrical. Shoulder is asymmetrical. So, which muscle is injured here and which has been injured in this case? Very easy one. Very easy one. So, which is the right answer, dear? I have got so many more MCQs to solve. So, we will have 10 minutes more. I think I will also need to eat something. I will ask the students what they will tell. I will do accordingly. Yeah, absolutely correct. Deltoid. Obviously, the IM injection is done in deltoid, and this will lead to the shoulder flat floppy atrophy, which will be the loss of shoulder contour is by atrophy of deltoid muscle body. The patient falls from a height. The patient falls from a height, and he is not able to walk properly. And what marked structure is involved here? So actually here you have to know about that injury of superior gluteal nerve. So which is the right answer? So you have to know, you have to identify that gluteus medius muscle. So we know that superior gluteal nerve is injured, Trendelenburg sign positive. The muscles injured is not acting as gluteus medius, minimus and tensor fascia lata. Abductors of the hip is not working, and the right answer is A. Again correct answer. So yes, here in this case scenario, the muscle which is injured will be gluteus medius minimus and that of tensor fascia lata, and the nerve being injured is superior gluteal nerve. So the following cell marked as A is connected to which structure? So the following structure marked A is connected to which of the following structure? Yes, right dear, cool, you are right. So following structures which is marked as the following structure which is marked as A, that is Purkinje cell fibers, are inhibitory to which structure? So the question is inhibitory to which structure? Purkinje cell fibers. You can see A is Purkinje cell fibers. So it is inhibitory to which structure? Deep nuclei of cerebellum. Absolutely right. Inferior thyroid artery supplies which structure? Inferior thyroid artery supplies which structure? Inferior thyroid artery give blood supply to which of the following structure? So basically it is giving blood supplies. It is giving inferior thyroid artery will give blood supply to thyroid, parathyroid and also thymus and esophagus. So we will go with D as the right answer. Yes, you are right. Yes, you are right. So basically all these following structures will give blood supply through inferior thyroid artery. So we will go with D as the right answer. Which cranial nerve is seen here? Which cranial nerve will be seen on the dorsal aspect? So basically the hint given is which is the cranial nerve which will be seen from the dorsal aspect here, the red color arrow. So actually the nerve you have to identify by the location here. Yeah. So here the fourth cranial nerve is the right answer. Actually, dorsal aspect of the brainstem, if I am talking about dorsal aspect, one of the cranial nerve is emerging from dorsal aspect, and that is the trochlear nerve, which will again come to the ventral aspect after decussation. So we will go with trochlear nerve. So here we will have the emergence of actually all the nerves other than olfactory and optic will emerge out from the dorsal, which will emerge out from the ventral aspect of the brainstem. Only the fourth trochlear nerve emerge from the dorsal and then appear on the anterior aspect of the brainstem. So which of the following will form? Which of the following is forming the pelvic diaphragm? We know the pelvic diaphragm is formed by levator ani muscle and coccygeus muscle. So in other words, tell me which is the levator ani muscle. In other words, tell me which is the levator ani muscle. So pelvic diaphragm is formed by levator ani and coccygeus. So in other words, just tell me which is the muscle forming pelvic diaphragm. So which is levator ani muscle? That is my question. Which is levator ani muscle? Which is levator ani muscle in this case? Actually, A, this is levator ani muscle. This is the levator ani muscle. So this is the pudendal canal. So basically levator ani muscle is the A. This is the levator ani muscle which is asked in the examination. This is the levator ani muscle. Yes. Now third part of vertebral artery is related to which structure? We know that third part of vertebral artery is residing in suboccipital triangle. It is residing in suboccipital triangle close to the posterior arch of the atlas. So it is residing close to the posterior arch of the atlas. So B will the right answer. Close to the posterior arch of atlas, we will have B as the right answer. It is residing in third part of occipital triangle. So B is the right answer. B is the right answer, dear. Which of the following lies in the infraclavicular fossa? We know that infraclavicular fossa we will have the coracoid process. So which is the coracoid process, dear? Which is the coracoid? This is acromial process. So this is A is the coracoid process. So A is the right answer. A is lying in the coracoid process. A is lying in the coracoid process. Slightly quickly I am going. A child with the is absent of the thymus gland presents with tetany. Which of the following marked structure is defective in this condition? So actually third pharyngeal pouch, thymus and inferior thyroid gland. So we will have C as the right answer. We will have C as the right answer. C as the right answer. So this is a case of Dijor syndrome and we know that abnormal formation of thymus gland is there and we know the third pharyngeal pouch give rise to thymus gland. So C is the right answer. Absolutely correct. COVID may spread to meninges and intracranial complication via olfactory, nerve rootlets, CSF rhinorrhea and olfactory nerve rootlets through emissary vein. I will come to most this structure forming foramen. This is known to structure forming superior boundary of foramen, epiploic foramen, superior boundary, caudate lobe of the liver. These are easy one and direct MCQ. My dear student, these are easy and direct MCQ. I will come to the most important sensations and questions, which is, yeah, one of this is this. Okay, this is a good question. So please, I will go most direct question. I am just rushing it because that is very easy for you to understand. Can you tell me this is a sign and symptoms where shooting pain is there? from the fingers and right shoulder, burning sensation when touches the core. So basically sensation has been increased. So this is a case of thalamic syndrome. So can you tell me which is the thalamic syndrome here? Which is the condition of thalamic syndrome here? So you have to identify just the thalamus in this case. Thalamus in this case. So hyper means the sensation, pain sensation, thalamic pain syndrome has been hyper. So this is a case of thalamic pain syndrome, and the right answer will be B is the thalamus. So definitely B is the right answer. B is the thalamus. B is the thalamus. So B is the right answer. So this is anterior fontanelle. This is anterior fontanelle, and in this case the structure being penetrated will be, in this case the structure being penetrated will be. So if you have to go and penetrate the anterior fontanelle in this in case of babies, you will go with scalp, dura and arachnoid. Scalp, dura and arachnoid. So definitely scalp, dura, arachnoid is the right answer. So basically identify the, so quickly I am rushing through this. Identify the bone. Which bone is this? Which bone is this? Which bone is this? Write down the name of the bone. This is incus bone. This is incus bone. This is incus bone, definitely. Yeah, dear. This we have done. This is islets of Langerhans. This is islets of Langerhans. This we have done. Actually, this is the slide of pancreas, and very nicely we can see this is the islets of Langerhans. So this is islets of Langerhans. This is a case of exactly the urinary bladder is protruding. This is a case of extrophy bladder. This is a case of extrophy of the bladder. The urinary bladder is protruding out. Extrophy bladder, definitely right answer. So in this case, there is fracture of pubic symphysis. See here, there is fracture of pubic symphysis and unable to pass the urine. Now the injury is superior ramus of pubis has gone. So whether the membranous urethra or penile urethra is gone. Now see the change of the scenario. Now the case is not bulbar urethra. Now the fracture is severe and the whole pelvic bone is fractured. So the injury will be in the membranous urethra. So the injury will be in the membranous urethra. This is a slide of which cartilage? This is a slide of which cartilage here? Definitely this is fibrocartilage. Definitely this is fibrocartilage. Which of the following structure is formed by the arrow marked structure? What is this? You can see liver. The hint is that this is liver, my dear students, and the liver is connected with anterior abdominal wall. So this is which structure, dear? Liver is connected with anterior abdominal wall. So this is falciform ligament. Falciform ligament. Absolutely correct. So this is pitting of the breast. This is pitting of the mammary gland and breast. And we know that pitting, orange peel appearance is because of the involvement of Cooper's ligament, the suspensory Cooper ligament of the breast. Suspensory Cooper's ligament of the breast. Now there was one question in which the form ballistic movement is there, and we know that ballistic movement is involving which nucleus? So we know that that is involving subthalamic nucleus. Subthalamic nucleus. Skin over the region of venous section, great. So we know that great saphenous vein is related to, my dear students, great saphenous vein is related to saphenous nerve, and injury is of the femoral nerve. Saphenous nerve is a branch of which nerve? Femoral nerve. Absolutely correct. So more questions are there. So my dear students, few more questions are there, I think, but it is okay. We have done many MCQs. Is it okay, everyone? I wanted to do more, but it is okay. Can we end the session now? So let me see the other type of question. Okay, this has done. The other kind of questions I want to just like for example, yeah, which of the following is involved in terrible triad? Other type of question. Which of the following is involved in terrible triad? So in terrible triad, unhappy triad, anterior cruciate ligament, medial meniscus and medial collateral ligament. So that means it will be C, it will be B and it will be A. Is it okay? It will be C, B and A. It will be C, B and A. That means A, B, C. That is C, B, A means A, B, C. Is it okay? A, B, C. A, B, C will be involved. Is it okay? Other kind of question. So one of the question is good. Which of the following is merocrine gland? So here this was image based question. This is hair follicle, my dear students. This is hair follicle. This is adipose tissue. So this is adipose tissue and this is the sweat glands and this is the sebaceous gland. Sebaceous gland. So sebaceous gland is, if I talk about sebaceous gland is holocrine. So we will have the right answer as B. B is the right answer, which is merocrine gland. B is merocrine because it's sweat gland. Sebaceous gland is holocrine gland. So this is the spermatogenesis and all. Okay, one of the question, these are all easy one only. This question, SRY gene is located on, this was certain SRY gene location. SRY gene location. SRY gene location, my dear. So the location of SRY gene which is stimulating. If I talk about SRY gene, it stimulates the Sertoli cell. It stimulates the Sertoli cells and leading cells, and it is located in exactly short arm of Y chromosome. So short arm of Y chromosome is the right answer. Short arm of Y chromosome. Neural column arrangement. So basically you have to know the neural column arrangement very nicely in this. So you have to know the location of the motor efferents and the afferents location from medial to lateral. So this is very medial to lateral. I want everybody to go through the location of the cranial nerve nuclei from medial to lateral. Let's go through this. Easy one. These are easy one only. Okay, I wanted to take so many. So please let me know, my dear students, can we end? We have actually, it has to be a long session if we have to go with each and every MCQs. Can I end? Is it okay? Then also we must have solved more than 100 questions. Is it okay? Can I end? Please let me know. Most important one, few only are, it's a most important topics and all has been done. High-Yield. I just want that you should go around the MCQs which has been asked in the last 5 years. Because in INICET exam, what happens, they will repeat the topic questions. So I want everyone to go around that most important questions and the topics. Is it okay? Can I end now? Please let me know. Ramesh, everyone, can we end now? Go through auditory tube also. Auditory pathway. Echo lima is the mnemonic for the pathway. Start from the whole pathway. Is it okay? Can I end now? Can I end? Can I end now? Blessings to you. Blessings to you. Already you have studied very nicely. Dr. Ashwani sir has already given you the anatomy very well. You are understanding everything. I just came for a quick revision of INICET important topic along with an MCQs. I hope this session is useful for you. I tried my level best to complete as many as MCQs I can. I actually few more MCQs are remaining, but I think it's quite late. Okay, thank you so much, and we will meet in the next session also. Don't worry, we will have quick sessions many of times if you require. Is it okay? All the best. Keep studying. My blessings are with you. Okay, so you are going to crack the exam. Have faith on you. Okay, thank you so much. Thank you so much. I'm just ending it. Okay. Okay, dear. So one time 24 के questions में आया था 24. What was that? Yeah. They have asked, this is question of 2024, the joint. That inguinal joint is saddle joint. Inguinostapedial joint is ball and socket type of synovial joint. Okay. All the best and keep studying. Thank you so much, dear. Thank you so much. Many things I still wanted to explain. Is it okay? No worries. All the best. Keep studying. Thank you so much. Thanks. Thanks. Thank you. We'll meet in the next sessions. Thank you so much. All the best. Thank you, dear. Thank you, dear. Thank you, dear.